appreciate the interest that you take in our Trust Board meeting. So if we could just please start with item 1, apologies for absence. I don't think we've got any, Jenny, have we?
No.
Okay, declarations of interest, you all have the paper. If anybody's got anything where they need to declare an interest with anything or a conflict with anything on the agenda, please do so and remove yourself from the discussions of that item. So could we please go to item 3, which is the minutes of the meeting held on the 28th of October. Are there any points of accuracy that you've not already let Jenny know? No. Are there any matters arising that are not on the matters arising action log? No. Okay, we'll take those as a true record then. Thank you, board members. If we could please move to item 4, which is the actions log. Any questions or comments on that? No. I'm just trying to find it. Okay, well, we were due to start our patient story next. Are we still waiting? Oh, Jo has joined us, I think, haven't she? I can see her at the bottom. So welcome. So I'd like to introduce our people that are joining us this morning. So we've got Joan, Jo and Mandy. Thank you all very much for joining us. It's very important to us to start with either a patient or staff story. It does set the tone for the board meeting, reminds us why we're all here, and we're delighted you can join us this morning. So Mandy, would you like to introduce this item?
Thank you. So we've brought today Joan. Joan is a patient care experience champion. I met Joan a year or so ago at the Carers Advisory Group, and ever since then Joan has been very heavily involved with the Trust in supporting the Trust in various activities. I won't say any more, so I know Joan would like to share her experiences with you. Joan cares for her husband who has dementia and receives services in the Trust, and she's come today to talk about her experiences. And Jo has very kindly agreed to come along as well. Jo has been supporting Joan and her husband in his care. Over to you, Joan.
Okay, good morning. I am here. Good morning. Morning, Jo. I'm here because of dementia. There are hundreds of us out there, all at different stages of our dementia journey, at times struggling to come to terms with our new reality. My husband is one of the most compassionate and helpful men you could meet, the sort who stops the traffic to allow an elderly person cross the road. However, public perception of my husband changed from "thank you, kind sir" to "go away. That man is interfering with me." The reality of our situation hit me in December 2018. Our 11-year-old granddaughter, worried because we lived alone, said to me, "Nana, do you know what to do when Grandad gets angry?" My husband was diagnosed with dementia in February 2013. However, we first noticed some memory problems in 2007. By 2009, his dementia was impacting on our quality of life. My husband is a very proud man and did not wish to be referred for support. In 2016, he agreed to us both attending a monthly Alzheimer's support group. By this time, we were isolated as a couple. Our previous very active social life had disappeared. One of the things that happens when you become a dementia family. We first entered the care of Humber Teaching NHS Foundation Trust in 2018 into the community mental health team in Beverley. Although back in 2013, we were part of a control group researching cognitive behaviour therapy and dementia. During August 2018, whilst out shopping with my husband, there were a number of incidents. Thankfully, we were in a dementia-aware retailer and staff were able to help. When I got home, I contacted the GP, who met with us both. I requested an urgent referral for psychiatric reassessment. The GP contacted mental health services and attached 2 A4 sheets of care notes written by myself raising behaviours of concern. The GP followed up on his referral to mental health services on at least 2 occasions. It was about 6 weeks before I had contact from the CMHT. During these 6 weeks, there were a number of other difficult incidents, and it was obvious my husband was very distressed. One involved my husband refusing to come into the house one cold evening. The out-of-hours service were called for advice. Several days later, my husband was admitted to Hull Royal Infirmary with a chest infection, pneumonia. By the time my husband was allocated a very supportive community mental health nurse, he was receiving day care 2 days a week. On one occasion, he found his way onto the roof garden, and they had a real concern he was going to throw himself off. I went to the day centre with some of his medication to calm him down. By the end of September, I was contacted by the statutory run day service to advise that due to his challenging behaviours, they could no longer care for my husband and he would have to leave. This led me to source private residential homes for support. When I visited these, it was apparent that they would not be suitable to support my husband. His needs were too challenging. In November, I arranged private day care 2 days a week at a private residential home in Hessel. By the end of January 2019, my GP was so concerned about my health, he referred me to a cardiologist. I contacted Private Home to advise I desperately needed some respite and asked if my husband could take the next available bed just for 1 week before it was allocated to someone, which they agreed to. During this time, I received support from the CMHT with counselling and supporting me to make decisions about his long-term residential care. On the 11th of February 2019, I agreed to my husband's stay to be permanent. On Valentine's Day, following a serious incident, the private home contacted mental health services. A crisis meeting took place on the 14th of February. My husband was sectioned. He was admitted on the 15th of February to Maester Lodge. This process worked well and was very organised. Myself, Beverley CMHT and Hessel CMHT were all involved in the meeting. Once admitted to Maester Lodge, I noticed a difference within my husband quite quickly. He could get agitated and aggressive. However, because he was in an environment with plenty of space, which was run by skilled staff, a lot of his agitation and unpredictable behaviour could be managed appropriately. There is a very clear traffic light assessment system within Maester Lodge, which works so well. The team has weekly multidisciplinary team meetings. I had a link to the meeting through the psychologist. During my visits, I got to know the staff and they got to know me. They have a much more proactive approach. Dr. Glover and the whole staff team were absolutely terrific at keeping me involved in decision making. I understand the difficulties the team has with the speed they have to work in, admitting and transferring patients. My main concern is the lack of appropriate, locally based, move-on placements for people with dementia who have challenging behaviour. We are one of the lucky few. When my husband was sectioned, there was a bed at Maester Lodge. Similarly, when the assessment period was completed, there was a bed in Castle Lodge. Many families in crisis are separated because the only resources available are out of county. As we are discovering with the COVID crisis, people with dementia need regular contact with friends and family to prevent an accelerated deterioration in their illness. At the end of May 2019, my husband was discharged to a specialist dementia unit in a residential nursing home. Gould CMHT and Maester Lodge offered extensive support to the unit. However, following a serious incident, about a week after his admission, the placement broke down and my husband was transferred back to Maester Lodge by ambulance at 11:30 at night. Once back in Maester Lodge, Joe was brilliant. We met early the following morning to review the care plan. The MDT concluded that my husband required a longer stay, secure hospital placement. Joe liaised with the CCG, and on the 3rd of June, he was assessed by Castle Lodge Independent Hospital. I visited the hospital and spoke to the ward manager. My husband was transferred into Castle Lodge on the 7th of June. With continued psychiatric support and a skilled nursing team, we were able to rescind the Section 3 Mental Health Act order earlier this year. He is currently still a hospital inpatient under the deprivation of liberty safeguards. I continue to be involved in his care, attending every ward round by conference call. It is our hope that he will be discharged at some point to a specialist dementia unit, which is able to offer him appropriate support. As my husband was now an inpatient, I was able to become involved in carers groups. I joined the Carers Advisory Group, where I met Mandy Dawley and found out about the work of the Patient and Carer Experience team. Mandy sent me an invitation to the next forum. Through the forum, I've become involved in a number of projects, from being part of an interview panel to recruit a mental health clinician, presenting and talking with a consultant psychiatrist to medical students. Currently, I am part of the Trust's Community Mental Health Transformation Programme, Mental Health Inpatient Redesign Programme, and Dementia Diagnosis and Post-Diagnosis Pathway Development Group. This involvement has had a positive impact on my own well-being, but I truly believe that the current developments will improve services and support to service users and carers in this area. Thank you for listening.
Joan, thank you so much for sharing that with us. Absolutely, well, very personal story, and you know, very much so, and we feel it through you telling us it. And I think also thank you in advance, and I know there'll be more comments about this, for your involvement and giving back to the trust. You really are involved, and I know that from Mandy, and I have to say it makes such a difference, and it's helping other people as well a lot, so thank you for that. Joe, before I take questions, is there anything you'd like to add?
I found that really moving, Joan. I remember it really clearly. No, I just remember it really vividly when he came in. The use of language by the care home, you know, by staff, we really struggled. Do you remember, Joan, some of the terms they used? You know, I just remember trying to educate the care home staff about, we don't say kicking off, and you know, it was really unwell when he came to us, wasn't he?
Yeah.
And that's about it, really. And he was a lovely gentleman to look after, and I think that's what strikes me, is the fact that the comments about him changed from being a lovely gentleman, and your friendships, you know, your circle around you all really changed. And I really can remember it quite clearly, and how involved you were. And it's difficult now because we don't have relatives on the ward because of COVID. But it was for much as your well-being as well, wasn't it, when you visited? Because you'd sit and have a drink with staff and we'd have a catch-up, wouldn't we?
Yeah, absolutely. It was such a difference to get into an environment where I suppose they looked at us as whole people, and it was all person-centered. It's because you suddenly become part of a family that cares, if that makes sense, except all the people have got lots and lots of skills around them, and they're using those skills to take you through it, if that makes sense. I mean, Emma was absolutely terrific. That's the psychologist. It was the first time that somebody could take me aside and actually sit down with me and explore exactly how I was feeling. You know, it was brilliant care.
Thank you. And I think you're the expert, aren't you? And that's what we're really very clear to all the relatives, the families, the carers. You're the expert. You knew him better than any of us. And we, you know, you were leading the way. You were saying this is out of character, maybe this, maybe that. So it wasn't just us, it was, we worked together, didn't we?
Yeah, it was a true partnership, yes.
Yeah.
That's fantastic to hear, and I think those who and most of the board know you, Jo, and they know Maester Lodge quite well. So, and you lead from the front on that. So, thank you to you, Jo, as well for everything you do, because I know you absolutely do everything you can to care for the people that are in Maester Lodge, but also care for the families. And we know as a board firsthand, for example, the recent lengths you've gone to about visiting and things like that. So, thank you on behalf of the board for everything you and your team do, because I know it is a challenging area to work in, but you really do make a difference and you really care, and that comes across. So thank you. So I'm going to open it up now to questions and comments. Has anybody got any questions or comments? I'll start with Lynn. You're on mute, Lynn.
That's not a good start, is it? Thank you, Sharon, and good morning, Joan, and thank you so much for sharing your experiences with us. It's an amazing story, and again, thank you so much for your contribution to us. That's fantastic. I guess it's a very personal story to me as well, actually. My mother-in-law has been diagnosed with dementia this year, so very, very resonates with the experiences we're having at the moment. Jo, my question is, given all that experience that you have, if you were to distill that, given the improvement programmes that you're part of, what would be the sort of one or two significant improvement areas, the things that you would want to get out of these programmes that you're really helpfully helping us with?
I think the biggest improvement, and I think is the links with GPs. My main concern is, I mean, when my husband and I met with the GP, it wasn't our GP, it was one of the partners who didn't know me, and within a couple of minutes he turned around and he said to us, I know exactly where you're coming from. But although he put forward an urgent referral, it was the time lag and the frustration from the point of the GP that he wasn't actually getting any support. Now, that is an issue that comes up again and again with other carers, where their GP, because they're generic, they're not specialists, and they actually need that specialist support and advice. I think the other issue for me is, again, it's a medical one. It's a very practical thing. At night, GPs, certainly whenever I was requiring support, GPs were actually using the same telephone number to access the out of hours support as members of the public. So, you know, if there's several crises out there, the GPs can't get actually through to it. So I think it's improving the links between primary and secondary care. I think, and also I think the networks, the primary care networks, will be absolutely brilliant once they get up and running. I think that's the main thing that I would like to see with the, happening.
That's really helpful, Jo. You're probably aware that is a key driver for the Community Mental Health Team Redesign Transformation Programme. But as you say, the dementia focus in that work needs to be front and centre as well. So I'll take that away from this conversation. Thank you for that.
Thank you, Len. John, you had your hand up. Is it down now? I don't want to miss you out.
No, that's okay. Just to reiterate, thanks to Joan. I suppose my own personal reflection on this is from our own family circumstances, where actually there was an element of shame around the diagnosis of dementia, and an in-law chose to sort of protect a family member by not wanting to talk about it, as opposed to Joan's approach, which is, dare I say, really out there and upfront, and in many ways is the ideal way to tackle it, because actually I think you're more likely to get what you need when you come out and articulate that there's a problem. But you need both partners at an early enough stage to have that insight, which Joan clearly has, to come out and want to talk about it, because the hiding it under a bushel just doesn't help families in the longer run.
Yeah, thanks, John. That's helpful. Dean.
Thank you, Chair, and thank you, Joan. My name is Dean. I'm just one of the non-executive directors, and just wanted to echo my thanks. I see some people have put in the chat room as well. Just thanking you for your time and telling us your journey, that sort of emotional journey that has taken place. Really moving. Thank you. It was a question for both you, Joan, and maybe for Joe as well. But you talked, Joan, about being involved with your husband being an inpatient now through COVID, and doing sort of virtual ward rounds. And I know this is a really sort of a topical issue for people around sort of care homes and in hospital, and whether you think that there's more that we could be doing to be involving you and making those connections. And Joe, as well, whether you've got thoughts and ideas on that would be appreciated. Thank you.
Well, firstly, Joe doesn't know this, but a friend of mine has actually been through a very similar experience during COVID times. And all I can say is the work that Joe and Maester Lodge did with her, with the restrictions on COVID, was absolutely marvellous. From the point of view, they actually had the contact that was so much needed to help both her husband and his wife, my friend, in getting through it. I think the difficulty was for people now leaving Maester, where they have that sort of support and they can have PPE type visits, is that then they move on from Maester and they move into residential care homes. And the issue is they are quite fortunate because there is a bubble in there, so at least they can see each other through the glass. But that is not ideal for people with dementia. It is both of our experiences is it's actually more distressing, and certainly my husband gets so frustrated because I cannot sit beside him and hold his hand. And I know other carers visiting their husbands in residential homes have actually stopped visiting because of the distress that's actually happening with the meetings with their husbands. And I think really it's not really so much a plea to the health authority, but a plea to the government, that they really need to go on. I mean, there's so many carers out there who are just saying, we've been promised to hold our loved ones' hands before Christmas, and the tests aren't going to be there. I mean, the tests aren't going to be there. I can't see it happening. I can see it happening maybe in January, but it's just going to be another frustration that carers and loved ones feel. And I think that's the only thing I'd like to say on that. But the model that Joe was doing with carers in Maester, I just take my hand off to her, and it just shows you the sort of person-centred approach they take.
So thank you for that, Joan. And I think a lot of the board have been involved one way or another, Joe, with that, haven't they? And they've seen firsthand the lengths that you and your staff have gone to make that possible for people that are in Maester Lodge and their families. And it really has made a difference, as Joan's articulated better than ever I could. So thank you for that. And I think we'll give the final comment and question to Michelle.
Good morning again, Joan. I'm Michelle, the Chief Exec, and just to reiterate what my colleagues have said, a fantastic, well-articulated story, thank you, and lots of really good learning as well, which we can take into not just the organisation but the system. And I think the point around GPs is really well made, and as we're developing both our models working with GPs and the primary care networks, we can feed those in. And I lead the mental health system across Humber, Coast and Vale. So I'll take on board some of that observations, Joan, and you never know, I might be coming to you for help and assistance in co-production some of the work going forward. So be careful about that. But no. You mentioned a question about what could, you know, the top thing, and you mentioned it in relationship to your hubby, etc. I just wondered if there's anything else that we could have done for you, because you know, you are just absolutely right about you being the expert and patients and carers being the expert in care. And I really do, you know, we really do try and support carers and their families as much as we can. Is there anything else that you think that we could have done, or something that worked really well that we should be looking at across the system and across the organisation?
I think, well, because I'm involved in these working parties that are going on at the moment within the trust, I think there's so many good ideas that are actually coming forward from the staff. I would say that I think the thing that would improve things, if all the organisations and the boards are actually working together, but there is still evidence that you know, all the different councils, all the different slightly different health authorities, whether you're a provider, you still have your own priorities, or it's not priorities, it's more to do with the pressures. I mean, COVID's an example. I mean, I don't know how people are doing their day jobs while actually planning and reacting so quickly to deal with COVID. And I think really what I suppose I want to say is it's very, very difficult when people are actually working to improve services, when they're actually going out and talking to service users and carers and listening, and they're bringing forward all these fantastic ideas, and they are fantastic ideas. And then there's suddenly a block because all the different organisations have got their own rules and regulations, and it blocks it. I just don't know. It just seems to block it. And that's the only thing I would say, Michelle. It's really, you know, it's about the organisations getting their act together, as well as the staff on the ground consulting with service users and carers.
Okay, I think that's a really, very, very good point. I'll take that back. And as I say, now we start to do more co-production as a system, and I may come to you. So thanks for those really pertinent points. And can I reiterate also, I think what everybody said about Maester Lodge, particularly in Joe, and I am going to embarrass Joe because you know that you and your team do some absolutely incredible work at the best of times. But throughout this year, you have spearheaded, led things like visiting, gone the extra mile in relationship to whether it's a conservatory or a summer house or a gazebo or a tent, even, to try and facilitate whatever you can in relationship to the patients and the carers that you look after. And it's not easy. I know we did a bit of refurb in Maester, but it's not an ideal environment. And just to go in, it gives me great pleasure to go in every time because the atmosphere is just fantastic. And you know, you do a remarkable job. There's some fantastic things in the message box, Joe, which we will send both to Joe, to Joan, and to you. But please send them to your team because it's an incredible feat that you do day in and day out with some of the most challenging, difficult patients that we have, and it is such a commitment. So thank you. And as I say, with the PP and everything else, and I know that everybody is really happy, so thank you so much, because you look after your staff as well as the patients and the carers, and please make sure you look after yourself as well, because you are too precious to us to anything else from a selfish point of view. But on behalf of the board, thank you and your team so much, and please reiterate that back. You are a credit to your profession and to this organisation. And thanks to Joan for your story.
Thank you. And as I say, thank you both very much. And Joe, I'm just sorry I can't come and see the Christmas tree this year, but I'm sure it'll still be. I'm sure you'll still be making the effort
going to be fantastic.
I know. Well, you'll have to send me a picture because I will miss. It'll be the first time in a few years I won't have been to see it personally. So yeah, please do send me a picture. And as I say, hopefully we have embarrassed you sufficiently during this story, Jo, to say thank you to you and your team, because you do deserve it. But Joan, thank you for your generosity in giving back to the trust and all those other carers and patients, because you really are working hard. I can see that, to, by the benefit of your experience, make it different for others and to improve things always. So thank you very much. We are grateful, and we look forward to continuing to involve and work with you. So thank you both very much for joining us this morning. Really appreciated. A fantastic way to start substantively our board meeting. So thank you both very much.
Thank you.
Thank you. Bye-bye.
See you later.
Bye.
Well, that was fantastic. What a way to start the board meeting. Really good, and fantastic to see Joan's involvement in all the transformation work that's going on. So that's brilliant. So if we just move on to item 6, which is my chair's report. As always, it's been a busy month since the last board meeting. I've had the pleasure of joining quite a few internal initiatives and events that have been going on this month, so including the Creative, a Fair and Inclusive Working Environment virtual meeting that was chaired by Grace Garver, the BME Staff Network Chair, and that was, I think a few of the board were on that conversation actually. It was a really interesting conversation. It was my pleasure to attend the Remembrance Sunday virtual service, and again a few of the board did attend, and thanks particularly to John, Mandy and even the team for that. Really important that we still, you know, mark the occasion, mark our respect and remember others. It was also my pleasure at John's invitation to present as part of the Quality Improvement Week, which is a fantastic week, an initiative got over the trust. And I presented the board's quality improvement project with due credit going to Jenny and Michelle Hughes, I have to say. I didn't steal their thunder, John, did I? But it was really good to hear the enthusiasm and all the interest, and they were well attended, I have to say. So probably more on that from John later. In terms, oh, and I can't forget the research conference either. And again, I know a lot of the board attended, but it's in Michelle's report. But what fantastic 2 half days held virtually, our 4th research conference. Congratulations again to Catherine and the team. I know it takes a great deal of work, but I mean, what a triumph. It really was a fantastic event. And I don't think it detracted at all from it, the fact it was virtual. So I'm sure I'll be really interested to see what they have planned for next year. So, and the last thing, just in terms of the internal work that's going on, and it shows you how much is still happening despite COVID, was I was delighted to attend part of the launch of the new online platform for the Recovery College. And great to see how much work's gone in and trying to make sure that things are still accessible to people, improving all the time. And the bit I saw, it absolutely blew my mind away. It was absolutely fantastic. So an awful lot of fantastic work going on there as well. And as I say, it's just amazing to see all these things progressing despite a pandemic going on at the same time. The credit to everybody. In terms of external meetings, I've carried on with the usual Humber, Kirsten Vale chairs and members meetings. Michelle and I met with Gwen Lunn and Alison Barker from Hull City Council, and I also attended a Yorkshire and Humber's chairs meeting, which largely focused on the proposed or potential legislative changes for the NHS. In terms of governors, again, it's been a busy month. I've continued to have virtual meetings with a number of individual governors. I've met with the public governors as well. And of course, we had a fantastic governor development session, which focused on our volunteer services, health stars. Rachel came and did a presentation on branding. And then Lynn very kindly came and did a presentation on winter planning as well. It was a really good session, and the feedback from it's been really positive. And I think that's all. So it's just if there's any questions for me. No, thank you. If we could then move on to item 7, which is the Chief Executive's report, Michelle.
Thank you, Chair. Good morning, everybody. The report is there that people will have had a look at. I'll pull out a couple of things as usual. I've done my usual annual review of portfolio. So the few changes that we've made are included. It's a little bit later this year because of COVID and because of the deputy post, but it's there now. So there'll be a few changes to some of the committees, but that work will start to transfer slowly and certainly be in place by the new year. I've mentioned Miranda House and PQ refurbishment because we are still pressing ahead with some of our capital work, even amongst the COVID work and the COVID pressures, because it's important that we try and maintain our environment to a high standard, and especially in the high areas that we've assessed as needing. Because of the urgency of the Miranda, and I have put this in for a specific reason, we have utilised our strategic partnership agreement that we've got with our partners at City Care, and that would expedite the work and it would allow it to be more or less completed by the end of the financial year, which is really positive. I have mentioned lateral flow testing. It is included in the COVID report, but we were one of the only 2 actual mental health trusts in the country. There were 34 pilot trusts a couple of weeks ago to start to pilot the lateral flow testing, and I thank John and the team for rolling that out so quickly now, and I'm sure we can have a conversation about that later in the COVID update. But we were a pilot site. It was a difficult process to start because, as you can imagine, we got a small amount of stock and then a large amount of stock, and the large geographical patch make it difficult, but we did choose some varied areas to pilot that on, and it's starting to roll out successfully, and other NHS trusts now are coming into that particular process, and I think it's a really important process is testing for me. One of the things that I've been saying both nationally and regionally is the importance of asymptomatic testing for staff, because it does allow us a little bit more flexibility. And the idea is that frontline staff test themselves twice a week at home. If it's a positive test, they stay at home and they get the full PCR test. If they have any symptoms of COVID, they don't do the asymptomatic lateral flow testing, they do straight to the PCR testing. If you have had COVID, you have to wait 90 days before you start the asymptomatic testing. But the idea is to start to really get that up and running as a regular occurrence. And staff have received it very well, and I thank staff who have been piloting that as well. I continue to dial into most of the teams across the organisation. Again, morale is getting a bit higher, actually. If you remember, we had a little bit of it was very high, a little bit of a dip. It's actually starting to come back up again, which is fantastic. But we still do have staff that are really tired. So we've been working with our colleagues at Shiny Minds and others, Lumia, and to see if there's anything else we could be doing from a resilience point of view. But what we are doing is publishing and pushing the Shiny Minds app again. If you remember, we purchased that months ago at the beginning of the pandemic, but there are some really great resilience pieces in there, so we are putting that out and supporting staff with that. We are continuing our hopefully monthly staff thank yous. This month we're sending out some face masks which have got the Health Stars logo on and the NHS our logo on, not for clinical use, but they're there for personal use, and again they've gone down very well, and we're just seeing what we can do in relationship to Christmas, because obviously we did the voucher in October, we've done the face masks in November, and we'll do a Christmas present at the end of the year, just to thank staff. I will remind everybody it's our international conference on Friday. We've got a few people from different parts of the world, Malaysia. I think we've got one from Malaysia, a couple from Italy, one from Spain coming to our conference on Friday. So if you've not got your tickets, please do. We've got Claire Murdoch, Ray James, Nav Kapoor and Alistair Campbell as the keynote speakers. And then we've got an update from each of the programme areas in the long-term plan for mental health. It should be a good session and a question and answer session. I have put into the report, and I thank Rachel and Adam and the team, just a bit of an update on the comms that we've sent out for COVID. I know you receive them every month, but I thought it was useful just to have a look at what we have done and some of the posters and some of the things that we've done, just to remind ourselves, really, because as I say, we do them on a monthly basis. So I just thought that was interesting for people. We continue to try and plan as much as we can for Brexit. Obviously, there's still some issues with ports. We don't think they'll be quite as substantial as they initially were, but we will keep you posted on that. BAME charity money, very, very great that we've been successful with that, our great charity effort, which is really positive. Lots and lots happening in the system. and I know that we're going to spend a time at the development day talking about that, so I'm not going to go too much today. Lots of work in developing both geographical patches, the Humber geographical patch and the North Yorkshire patch, as well as the infrastructure in the ICS, and I'm playing quite a strategic role with Stephen and the team in relationship to that. I'm also doing some work, I've just commissioned Mike Farrow to do some work on the collaborative work as well, not just the mental health and learning disability collaborative, but the other two collaboratives, the acute as well as the community one as well. So lots and lots of things happening there. Revised legislation looks like there will be something in the new year, and I'll pick up a little bit more about that in part 2. And then there's the various directors updates, and I would like to take this opportunity just to thank the executive team for all their work and support. It is a very challenging time at the moment with staff testing, getting ready for the COVID vaccine and the flu, and I'll leave Steve to pick up on the flu, the latest flu targets and what we're doing about that, Steve and Lynn. But I'll leave it there, Chair, unless people want to ask any questions on the report.
Thank you, and I know Mike's got a question, but before I go to questions, are there any executive directors that just want to add anything to any of their parts of the report they're in before I go to questions? Yes. Michelle, I haven't forgotten about the policies, don't worry.
No, I was just going to add, Chair, if I may, before questions. There's quite a lot in the communications update, but just to draw out a couple of pieces further, there's a statistic there, 89% of our COVID comms are being read by staff, and the ability of Popolo to provide this data is another way of providing reassurance that key messages are being read. Again, the Unbelievable recruitment campaign is maintaining its impact, a 35% increase in visitors to the site. And finally, I just wanted to draw attention to the awareness days that the team promote each month. And earlier this month, one example was the International Stress Awareness Week. We not only had strong internal support from staff and colleagues, but we shared our assets, and they were used across the patch by our partners and other organisations who felt they were also beneficial for their staff and networks. So I just wanted to highlight that as, again, an increase in the reach of our quality work and brand with partners.
Thank you, Michelle. That's really helpful. Yes, I saw one of the CCGs had used some of the work. I saw that myself. So yeah, well done. They continue to do fantastic work, the team. So please send our thanks on to them. So I've got a few hands up. So I'll start with Mike Cook, please.
Thank you, Sharon. Good morning. I suppose a couple of thanks. Just to start, I think this is a really good report, Michelle and the team, and thank you for your response in what has been a very strong local surge in the pandemic, particularly around Hull, because I know you've been extremely busy, as well as then piloting various things, as well as still doing a brilliant research conference. I think a blended format next year could be really good, something hopefully physical and also this great way of communicating. So I thought that was excellent. Can I thank you for the COVID communications are excellent, and they're being used by other organisations outside the NHS as well as within the NHS. And it's great to see the summary. They are regular, clear. There's another one that will show you that John, I'm sure, will highlight on the visiting protocol. Really, really good stuff. In terms of, can I also just thank Steve? He's just sent out a retirement booklet to a few of us and probably a lot of staff, but it shows the options, what you should think through. Very practical, very clear, but actually really nice and full of our values, the way it's talked through. So some good stuff there. A couple of offers. I'm very happy to talk to you, Steve, about the Charitable Funds Committee, obviously, because you're taking the lead on that now, but also this exec coaching and the high performance, high potential programme. If you want to have a chat anytime, I know there's one or two others have been involved in those, but I've set one or two of those up in the past. So very happy to do that. And if I may, can I just ask a couple of questions? And they're afraid they are for you, Lynn. On 4.11, the the community mental health team transformation is a really important programme. So delighted to see it. Could you just update us on, of the 86 new net staff, how many we've recruited, what's the trajectory to try and get more, and what impact it's having on the particularly the mental health inpatient areas, if staff are just transferring from there? And just finally on the mental health inpatients, there isn't any mention other than beds of a research hub, an involvement or recovery space. And I would like to discuss that with somebody, because I think it's absolutely vital for the future to build on the massive progress we've made in that in the last 3 to 5 years. So they're for you, Lynn, the questions, but thank you again, everybody. I can see how you're working on so many levels, and I'm looking forward to the international conference on Friday. Michelle, well done putting that together. Again, system leadership or what? Lynn.
Yes, thank you, Mike. So in relation to the Community Mental Health Transformation Programme, so a really significant programme. It was interesting to hear Joan reference it earlier as well, because it is right across adult services, obviously including older people too. So to answer your question specifically, we have recruited now all of the non-registered workforce. Now the skill mix for this programme of work we thought very carefully about right at the beginning. We knew we were always going to be challenged with registered workforce anyway, so we really attempted to create the right skill mix that we were going to be able to recruit that actually met the objectives of the programme. So quite significant numbers of the total 86 whole-time equivalents are, for example, peer support workers. They are health and well-being coaches, but there is an element, Mike, of registered workforce too, nurses, social workers particularly. We are still a bit challenged around recruitment for those. Those posts have been very much front and centre of the Humber campaign. We have recruited, and we have recruited externally as well. We've now got sufficient staff that we've started implementation across 3 PCNs. Our trajectory is to obviously complete that rollout across all 12 PCNs by the end of March. So as soon as we create sufficient mass of team, we roll out instantly. So we are deploying as we are continuing to recruit. We have looked at the skill mix again. We've adapted roles a little bit more, even from our original intentions, in order to be able to recruit sufficiently. But we're working really hard at it, but we are making good progress. Your other elements about, are we robbing Peter to pay Paul? I think taking staff from elsewhere because of the skill mix, we're not seeing significant impact in relation to that. In actual fact, we've been able to recruit a little bit more as well to our mainstream community mental health teams, specifically social workers, interestingly, at the moment, but we are watching it closely. I'm actually pleased with where we are with the recruitment. It is one of the biggest challenges. It's the biggest challenge as well that all of the other early implementer sites are also reporting to. But I think we're holding our own in comparison to where some of those other sites are. In relation to your next question, so we have included, I can assure you, not just the focus around inpatient beds, but that notion of using the new mental health inpatient facilities to be a hub for research and recovery is very much front and centre. So that is included in the outline business case. EMT have now had the first draft of that. We're just doing a little bit more refining of that. And when you see it, because obviously it will come through to the Finance and Investment Committee and obviously then ultimately to board, but I can share that strategic case with you and Mike to assure you that those elements are included.
Thank you for that. I'm just concerned that will be the first thing to go if we start having to look at costs. So I would like to see that, and I would like to see that front and centre in the way it's reported to. Thank you.
Thank you both. That was really good. Francis.
Thank you, Chair. Mike's picked up on a fair bit of mine. I agree. Really excellent report and great to see all the stuff that's going on despite COVID. On the recruitment front, there's also the young people service. So there's a lot of recruitment going on. Presumably, Steve will pick that up as part of workforce as well at the next workforce meeting. Start for Steve.
Steve, do you want to pick that up, Steve?
Yeah, can do that, Francis, no problem.
Great. In terms of the conference, unfortunately, I'm teaching on Friday. Are we recording it, Michelle, so that we can see it at a later stage?
Yeah, we're hoping to do that, yes. Yeah.
Excellent. A couple of others. Just to say, the annual research conference, I sat on both sessions and I thought it was really, really impressive. Some really fantastic talks, some great learning there. And a credit to everybody, particularly John and the team, about how they put it all together, how it was presented. I think this day 2 presenter was much better than day 1, John, but you know, that's the way it goes. Great on the Civic Award for Eve. That's fantastic to see that she's been recognised on that. And when's the continuous professional development day? And again, are we able to sit in and just watch, observe, or anything?
So that's for the psychologists, Mike, and is pretty much internal to them. But I'll go back and I'll ask the question.
If it's a problem, John, don't worry. But it'd be just nice to sit in and quietly observe and see what's going on if it's possible.
Okay, I'll ask the question, Francis.
Great.
Yeah, thank you for that, John. Jenny will just circulate that outside the board meeting, just round when John's asked the question. Thank you. Anything else, Francis?
That's it. Thanks, Sharon.
That's great. Thanks. I've got Peter, but Mike Smith, did you have a question? Your hand was up.
Yeah, thanks. Well done on the training. Really pleased to see that the development scheme applies to bands 2 to 7. That's really inclusive, and there are so many trusts that concentrate on the higher level stuff. You go from induction to management training in one, well, after a few years. And the thing that concerned me though, and I think it might be historic now, is the flu figure, 37%, and the final deliveries here. That just doesn't read right. But it was on the 9th of November, which is a fortnight ago. But I just wanted some assurance that we were on target with flu jabs, please.
Thanks.
Yeah, it's a good point actually. I was going to pick that up because we are specifically under a bit of pressure at the moment with our flu target. If you remember, we've steadily year on year increased our flu target significantly. I think when I arrived, it was sort of about 30%, and I think last year it was nearly sort of 75%. But this year we have to expedite it in a couple of weeks. So we've given the trajectory target to the end of this week, if not next week, which is causing obviously some pressure. We have got a lot more peer vaccinators this year. I think we've got sort of 80 across our geographical patch. And we have had a late supply of vaccines, which has been part of the problem, to be fair. But if you remember, I did suggest that Steve or Lynn would pick up just where we were up to and what the trajectory was. We're having to report on it daily, the figures, because obviously we want to get that out of the way before we actually start to administer the COVID vaccine, which we are planning with our colleagues across Humber Coast and Vale. But Steve or Lynn, do you want to pick up where we're up to today and what the figure is yesterday? Because it is slightly better than that, but we've still got some significant way to go. So Steve, do you want to pick up that?
Yeah, so the last figure that I saw, I think we were at 45%, but as you can imagine, with 80 peer vaccinators in the trust, we're getting data through all the time on a daily basis of the completion rate. So literally that changes by the day. As Michelle says, we
49.7%, Steve.
49, so there you go, it's already changed. So we've got the plan. What we can say is that in the letter that was sent to us, that we offer all of our 100% of our front line have been offered it, and that stands. We've done that, so everybody's been contacted. We've got enough vaccines for everybody to have one who wants to, and we're in the process of kind of rolling that out. So as you will have seen, we've done videos, comms messages. Francis is our flu champion, has had a picture taken of him having his, and we've done a number of different things to do that, not least Michelle meeting all the an open session with the peer vaccinators last week to talk about it and say how important it is. So looking across and comparing what we do compared to other trusts, I'm not sure that other trusts are doing anything different to we, and in fact some aren't doing as much as we are to incentivise and to push it. Hopefully we'll see those figures keeping to increase as the days go by.
And don't think we have linked it to an extra annual leave day, and we did our own flu animation as well, which we do need to push out. And John and Hilary are writing in their capacity that they're heads of the professions category too, particularly the clinical groups, because unfortunately, and I will say this, I'm a nurse. It is the nurses that do need to continue to increase their uptake. Year on year, medics don't do too badly actually, but it is the nursing particularly. But we are all over it and looking at it on a day-to-day basis. But it is a lot to do, but we will continue to strive to do that and deliver. John?
So I think there's a couple of things just reminding ourselves of. Firstly, we've been working on flu plans right back from July, and the original plan would have been based on a full rollout by the end of December with an ambitious target. And interestingly enough, when we compare our figures at the end of Friday to this time last year, I think we're about 20% ahead on delivery to where we were at the same time. So if you compare the trajectories, our current trajectory is going up like that, but it still hasn't got us to the 80, the 85% where we want to be. And bearing in mind, that's a stretching target for us, because last year we were at 75%, which is improving. So look, I'm confident that with the 80 peer vaccinators and the continued support from people, that it's going to continue to climb. I think the one thing we just need to note is the understanding the idea of clinical facing staff, because since COVID has come in, an awful lot more of our staff who are what you call patient facing are now remote working. And that's not a bad thing, it's a good thing, but actually a lot of people are now working from home, so don't necessarily come into bases or work from a base that they would traditionally do. So I'm not quite so sure that the NHS understands the difference in the staff makeup, and actually the challenge around asking staff to come in for a flu vaccine when they're predominantly working from home. We're all on the same page. We believe flu jab is a good thing to have, whether you're walking around Tesco's or whether you're coming into work. But I think that some of the dynamics and the subtleties have changed, which I think is just helpful for me to put out there. But undoubtedly, there is a professional responsibility on doctors as much as nurses and our physios and our AHPs to get this done. And I'm confident that we've offered this to people, and I'd be confident that we will get there. But just to understand that our clinical facing workforce is now different to what it might have been 6 months or 9 months ago in terms of where they're working from. But more to do with an ambition to do it as quickly as we possibly can before we hit the COVID vaccine wave in the next couple of weeks.
Thanks, John. That's helpful. Peter Barron.
Yeah, good morning. It's just a quick observation or question on Brexit, because this is the last board meeting before we have the Brexit transition on the 1st of January. So, I appreciate what Michelle said, and I realise we've probably got everything covered, but you never know. I mean, we don't know what we don't know, and I guess it's just to say that as it's at a time of year when maybe senior staff and directors are scattered a little bit, I just wanted to make sure that there was a chain of command sort of available, just in case there was a last minute hitch, problem with the ports and issues with the motorways, etc., so that we've got some sort of chain of command available and a communication plan available just in case there were issues that were possibly unforeseen came up at the last minute.
Yeah, yes, we do have all that. But obviously, we revised our own Brexit planning guidance that we did, and the policies and things that we did prior to COVID starting. Because if you remember, one of the main aspects was the A63, people coming off the docks. I don't feel that's going to be as relevant this year with the border potential controls that they're going to put in. I'm going to hand over to Pete, and obviously we're just in the process of moving the SRO, but Pete's been doing the work. If you remember, Peter Redding's the lead because of the position of NLEG. But Pete, do you want to pick anything else up that we've not mentioned?
Well, I think you covered a bit about the command arrangements and the emergency planning arrangements, Michelle, and I guess the assurance we're getting from the national team, Peter, so Keith Willett's team, is that national arrangements for continuity of supply, which was probably the biggest concern in terms of the port, are in place in terms of category A freight routes, stockpiling of medicines and devices. So we're getting that assurance from the national team and getting a very clear message. It's business as usual. I guess I do know national cells are being established if there are shortages, but I don't know if John wants to come in, but we often deal with shortages of medicine supplies as part of our normal course of business.
Yeah.
So Peter, just to add to that, Pete, Keith Willett, who's the National Strategic Director, and he's been explicit in his webinars to senior clinicians and managerial people that the centre have it all in hand, that there will be no problem with supplies, and we are to continue with our current process, which is for us about keeping 7 days worth of stock, and we have been prohibited from stockpiling because of those guidelines which have been in place for a year, Peter. So my personal perspective is the centre have guaranteed us that supplies will be maintained, and we will retain our confidence in that. And just to pick up the point that because of the way the trust has been organised over the last 9 months, Peter, we have a gold command. So I think most of the execs were working over Christmas and New Year. So even if there is a challenge with regard to Brexit, or dare I say EPO arrangements, which we've had in place for the last 9 months for COVID, will be picking that up as well, Peter.
Thank you. Good question, Peter. Thank you all for that. Is there anything else? No, well, we're asked to, I think there's some good questions to debate there. We're asked to ratify the policies that are in the paper. I think it's page 40 of the pack, and there's 1, 2, 3, 4, 5 of them this month. Are we happy to do that? Yes, any dissension on that? No, we'll ratify those policies. Steve, I don't know, do you just want to give us a, before we move on, do you want to give us a brief update on the staff survey, or do you want to do that later?
No, I can do, Sharon. So it closes, the staff survey closes at midday on Friday. So we got our latest figures at the beginning of the week, and we're at 40%, which is what we achieved overall last time. So that's good. Hopefully, you know, we usually see a rush in the last week of people completing anyway. Nationally, the return rate's 42%, so we're just behind the average in the NHS at the moment. So we did some comms out from EMT yesterday, just reminding people, making sure people have got the time to complete it. And we've had a regular comms going out from my team and the communications department as well anyway during this period. So hopefully we'll be able to get that rate up, exceed what we did last time, and then we'll bring the reports back into workforce committee and board when they come out in the new year.
Thanks, Steve. That's really useful. Jenny, Jenny Bradley's joined us for item 15. Jenny, you've got your hand up. Is there a question?
Yes, yeah, just to add what Steve put, any issues, our helpline, you know, is open all the time to help people complete via the phone. We do kind of get quite a few rush, as he says, towards the end of field work. But if people are having any issues with returns via emails, our helpline is still up and running as normal. If that helps, Steve.
Okay, thank you very much. Jenny,
thanks, Jenny. Thank you.
Thank you for that. If we could just conclude item 8, so we'll conclude that section of the board, and then if board members are agreeable, I'd like to go to Jenny to item 15, just it's not so we don't keep Jenny waiting while we go through the intermediate papers. So Michelle, if we could just go to you for item 8, please, the publications and highlight report.
Yeah, thanks, Chair. Again, I'm not going to go through this. People have had a chance to have a look at it. This is all the publications that have come in over the last month with the relevant director comments, and I'll just throw it out for questions, Chair.
Thank you, Michelle. Any questions on this paper? No, I think it's quite comprehensive. Thank you. So welcome, Jenny. Lovely to see you again. And John's pointed out it's 10 months, I think, since you were last with us, so not quite the year that I was saying that. I can't believe a year's passed, but it's still a quick 10 months. And an awful lot's happened, hasn't it, in that time, indeed. So welcome back to the board, Jenny. It's lovely to see you again, and over to you.
Thank you. So I'm going to attempt to share my screen now. Please tell me if my slides aren't moving along. I did an internal presentation the other month, and they waited until I was halfway through a 20-slide pack to tell me I was still on the first slide. So please tell me if there are any issues with this. Okay.
John, is there anything you want to say just by way of introduction?
There is. So very quickly, Sharon, normally we have this presentation in January, but over the last 3 years as part of our improvement work, we've been trying to sort of move our improvement work forward. So in other words, we look at the early data as soon as we get it, and that starts to inform the internal work of the trust. where Mandy's been working with our operational colleagues to roll out a series of improvement workshops. So we have to work within the boundaries of obviously the public, the embargo on publicising the data. But I think we've been really successful, particularly in the last 2 years, of getting that work up and running. And I think we're starting to see the benefits of this. And the public embargo ended on this yesterday. So I'm really pleased that we can do this one day hot off the press, because actually come January, February time, we'll be starting to think about the next set of field work for the next set of questionnaires. So this is as early in the process as we've been ever managed to do it. So I'm grateful to Jenny for supporting us to do it with that, because it just means it just feels a bit more current from my perspective and from the team's perspective.
Thanks, John, and I applaud your planning, the efficiency of it one day after the embargo. That's pretty impressive, so well done for that. So Jenny, over to you.
Can I confirm you can all see my my screen for the first slide is full screen? Is that visible there?
It is, Jenny, yes.
Wonderful.
Thank you.
And am I scrolling through onto the next screen? Can we go onto the screen that says background?
Yes, that's perfect.
Wonderful. In which case I'll continue as normal. Yes, thank you so much for having me back. And I can just reiterate what John's saying there. It's fantastic that they're so hot off the press here, getting the action plans into place. I do always find the national results for this particular survey interesting, because there does always seem to be, I say, more of a lag on the national results being published than some of the others. So I think we got our reports out to you sort of around August, with the management reports, with your initial data coming sort of even sooner, but obviously we're only just getting the national results now. I will always go through the background. I'm sure you're all aware and probably seen this slide a million times before, but for anybody who is new, the background to the survey, it's part of the NHS framework. It's one of the mandatory annual surveys that trusts such as yourself have to undertake, and it's a source of data for CQC under inspection, but it also gives yourself an insight to any differences between maybe what clinician reporting and patient reporting. The CQC's role is to organise the national patient surveys. They set the questions, they undertake the national analysis and publish the comparative data. Our role is to deliver the surveys on behalf of yourself, but we also give you insight into the results before the national data, and can support you in ways such as this, such as presenting the data and explaining any issues to you. I'm not sure if this, so it's run on paper only, fieldwork between February and June 2020, and the samples designed to ensure sort of good comparability between trusts over time. What we'll be looking at today is actually the report from the National Benchmarking Report, which was published yesterday. In terms of changes to the questionnaire, there was one new question added for the survey, which is question 29, but it's not actually a scored question. And the question that was removed was actually from the support and well-being section around peer support. So they often, if they put a question in, they take one out. So this slide here was one that I put in yesterday as I was reading through the national results and the benchmarking results. They do report on the impact of COVID. I'm going to try and summarise it here. If you do want to sort of know more details, I would direct you to the statistical report published by the CQC, and they've got an appendix there where they've done statistical analysis into the impact of COVID-19 and results. So the peak of the pandemic and the national lockdown did occur approximately midway through the fieldwork period for the survey. And they have done some in-depth analysis that has shown that the national lockdown has likely impacted on the way that service users responded to the survey, with results actually being more positive. They haven't given sort of real reasons for this. There's some sort of discussion around people who responded to the survey before going into lockdown and after going into lockdown. With those going after into lockdown, actually they're the ones who tend to report more positive than in previous years. They give some ideas that the differences might be attributed to the way that services were delivered, or potentially the perception of the NHS support for workers, and they've coined this term the NHS gratitude effect. So for these reasons, they've actually deemed the 2020 results as not directly comparable with previous iterations. But that said, I think it was important to have a look at your 2020 results. So they are in here, and they're presented from your national benchmarking report from last year, and they're included sort of as a guide, so you can see the difference. So the results do actually include a combination of the responses completed before lockdown and those completed during lockdown. And that final point there, do consider this when reflecting on your results for individual questions. So in terms of response rate, the trust is performing well compared to the national results. You had 30% response rate compared to 26 overall, and that's also a slight improvement on the response rate for 2019. So as we go through the report, we'll be looking at thresholds, and these are we call them red, amber, green, but you've got green, red, grey here, where if the trust is performing in the expected range of other trusts, it's coloured grey. If it's below most other trusts, in the charts I'm looking at, they're actually yellow. And if you're performing better than most other trusts, then it's scored in green. And actually 32% of the questions in the survey scored better compared with most other trusts. So it's a really positive result. None of them are actually scoring worse compared with most of the other trusts. All of the others are within the expected range. And quite a few are actually towards the top of the expected range as well. As we go through, we'll see that. I've just put this slide in here about the top 5 questions, because this is kind of quite interesting if we look at the scores in their own right. So which scores are high or low, not taking into account comparisons between others. So you can see here you have got the full marks here for everybody saying they know how to contact person if they have concern about their care. And you've got other good performing scores along here in regards to respect and dignity, the organising of care and services, and discussing how care is working. And I think we'll see as we go along how these feed into your section scores as well. And then the bottom 5 questions, I probably could have guessed these without even sort of seeing results. They tend to be the same ones every year, which is this newish question around giving feedback, and then the scores around support and well-being. And what's interesting about the scores around support and well-being is you can see here they're low in their own right, but as we go through, actually you do have some of the best scores among other trusts. So this is why it's important to consider not only how you're performing compared to other trusts, but how those scores are in their own right. So this slide here is the section scores. So we've got all of the section scores listed, and then these little charts that we're talking about here and how you're performing. What I like about this is it also sort of shows you the range of scores between the trusts. So we can see where there's certain questions where there's sort of big disparity between top and low scores, where everyone sort of seems to perform well up towards the top as well. So you can see here you are performing better than most other trusts on the section score around planning care, reviewing care, that support and well-being section, and also possibly sort of like most importantly as well, the overall experience. So you can see here, even where you haven't quite got into the top best performing, you can see right on the edge there around health and social care workers, organising care as well. So it's a nice little sort of overall viewpoint for you. So going into the scored results section by section now. I think I'm going to be saying the same thing across most slides, is that the fact that the scores are very positive. You've got a score performing better than most other trusts by giving enough time to discuss needs and treatment, and then the other scores are up towards the top end of the expected range as well here. And you can see that, and I think most of the questions as we go through from 2019, as I say, bearing in mind what I've already said, will show improvement from 2019. Organising care here, this is again a really good score that's just on the brink of being in the top as a section score. And this is that top score here. Do you know how to contact the person if you have a concern about your care? Is one of the best scores. Well, that you can get much better than that out of all of the trusts there, scoring everybody saying that they knew how to contact the person in charge of organising their care. Planning care, this is one of the section scores that was in the top expected range. And again, as well as question 12 and 13, involvement and agreement of care being better, again, they were one of the top, performing trusts. So I don't know if anybody else got that same score as well, but nobody got any better. So that 7.9 and 7.4 there compared to other trusts, nobody got any better than that. So again, really good story. Reviewing your care. Again, this one was a section score that was in the performing better than other trusts. So the reviewing your care, I don't think it's difficult to say all of that's on COVID-19, but a big improvement there from 2019 in terms of having a specific meeting, and then decision making remaining very stable. Crisis care is still in the expected range. But this last score is possibly one that we'd look at for further improvement around getting the help needed when trying to contact this person or team. And certainly crisis care is going to be one for focusing on, I would have thought, in the future. And might even sort of be interesting to see how people report on this in the next survey if they're reflecting back on this year, because certainly in the national report they were talking about a rise in people seeking crisis care, and that might be something be nice, interesting to discuss at the end of the presentation, how you found that and how that's feeding into what your anecdotal evidence says. Medicines, all within the expected range. The score that I always flag up in this one, and probably anyone's been to one of my presentations again will have heard me say this, and I say it too in an inpatient setting as well, is always around the side effects of medicine and seeing if we can improve that score there, because we know that side effects can potentially be a reason why people don't take their medication as well. So that score there, room for possible improvement in terms of explaining those. NHS therapies, again, within the expected range, explanation scores high, involvement not as positive, but still within the expected range. And then the interesting scores around support and well-being, whereas you can see here you are scoring better than most other trusts, and that 5.7 is sort of one of the best scores there for around help and advice with financial advice and benefits, and all of these scores showing some improvement. But again, I will always sort of flag this up one to continually looking at, because those scores in themselves aren't particularly high, apart from the last one around involvement of family. Feedback, again, this one that is sort of historically low and low across all trusts. So apart from this questionnaire, have you been asked to give feedback? And then onto the overall views of care and services, positive results there around being treated with respect and dignity. And there has been an improvement around feeling that they've seen NHS mental health services often enough for their needs in the last 12 months. Again, this will be an interesting one, perhaps more on the next survey as well, depending on how you feel that you've reacted to COVID and remote appointments. And again, it'd be really interesting to sort of discuss that with you and see how you felt it's gone. And then the overall experience here, up from 6.9 to 7.6, up within the better range there. And I think this is obviously a culmination of all the other improvements that have made throughout the survey that have then fed into this overall rating of experience. So again, just a real positive story within the trust. So observations and recommendations. I've not made sort of specific recommendations this time round, but what I would say that is, even discounting the COVID-19 effect, the results do show a positive picture for the trusts, with all of those sections and individual scores performing better than other trusts. And this is certainly something that I think you should be celebrating and sharing with staff. Things to consider would be how to maintain the high scores moving forwards and prove that it wasn't an effect of external forces such as the lockdown and COVID. And areas for further focus, I think, for yourselves should be those with sort of maybe the mid to low, what I call this, the absolute scores, the scores that aren't particularly high in their own right. So feedback, continue working on those support and well-being scores, the actual help people receive when contacting crisis care, and the side effects of medicine. So all of the results are actually on Solar now as well, which means you can dig into those results in more detail across age, protected characteristics, and any other benchmarking markers that you've put in there. But that's the end of my presentation, and I'd be happy to take any questions and try and answer them for you.
Thank you very much, Jenny. Very comprehensive as always, and it's really in the covering paper, which I don't know if you've seen it, Jenny. It does mention some of the targeted areas from last year and the response this year. So, for example, the one about where we got 10 for do you know how to contact this person if you've got a concern about care, that was one of the targeted areas from last year's work. So
wonderful.
So that's good. Just before I take a question, I'll come to John because obviously you've got the lead for this, John.
So thank you, Sharon. I think at some stage it would be helpful just to bring in Mandy just to talk a little bit about the ongoing work that we've done. I suppose just to refresh the board, we actually discussed this in the sort of initial management report in detail back in September, where we did a lot of comparative work, not just to last year, but the year previously. And it's interesting to sort of pick on the 6 areas of focus of last year, particularly around medicines and medicines management, has significantly improved. Now, undoubtedly, irrespective of the COVID effect, these are a really good set of results. But like I remember last year when we had some lower scores, I quoted Kipling and his poem If, sort of treating disasters and victory as imposters. So, you know, I think for us, it's bank this, it's great. It shows that some of the improvements are absolutely taking place over a 3 to 4 year period, which is what we've reviewed. Particularly pleased to see the medicines management approach is improving year on year. And I think part of that is because of the involvement of pharmacy and pharmacy techs in terms of delivering a new model of care. So to my mind, it's about making sure we maintain this momentum. Picking up 1 or 2 areas for improvement. I think we'll have to think a little bit about digital literacy and digital access, but I don't want to steal the thunder of Mandy, who will just give you an operational overview of what's happening with the teams on the ground going forward, because we've had this data since August and have been working on it.
Thanks, John. Mandy, thank you very much for staying for this item. So we'll come to you, if that's all right, Mandy.
That's fine. Yes, so I'm working closely with our mental health planned and unplanned divisions. We've held a workshop back in September to look at the results internally and to look at how we can make further improvements. The group decided as a whole that it would be a good idea to continue with our existing action plan because the results are so good this year. We want to further enhance the work that we're doing there. I'm meeting with the unplanned division as well, where we're working on the same action plan set. So certainly from the contact with crisis services, that's an action that we'll be further implementing over the next few months. So as a whole, the organisation is very supportive of these results. We will be thanking staff in our own way in the next couple of weeks, but I don't want to say anything just yet. I want to wait for that one. We've developed a working group, and the working group is going to meet on a quarterly basis. It's going to be operational led with support from my team, whereby we are going to continue to review on a quarterly basis the results. We know that the next survey starts again in February, so February to June. Our working group will be supporting their staff to ensure that we're fully prepared for the next survey. So rather than it being we're getting the results, then we're doing something about it, we want to be proactive before the next survey actually starts. So we have absolutely turned around over the last 2 years the way this survey actually works in the whole process. So it's really positive, really promising, and it's wonderful to see 100% in one of our scores. So yeah, we're really pleased with these. There was just one thing that I wanted to check with you, Jenny. When I looked at the graph, the thresholds graph that says how many, what percentage we score in the mid-range and what percentage we score in the top range. I think the figures are the wrong way around. It said 9 questions we scored better, and as we were going along the presentation, there was more than 9 questions that we scored better. So I think that the donut graph, I think the figures might be the wrong way around.
I think Jenny's just
slide 7.
Scrolling back.
It's slide 7.
That's helpful, Mandy. Thank you.
Okay.
I think it's slide 7, Jenny.
I think the 32% should be the grey and the 68% should be the green.
Green.
I think you're on mute, Jenny.
Sorry, we still can't hear you, Jenny.
No, hello, can you hear me now?
Yes, we can now.
Yes,
Thank you.
no, 9 scores scored better compared with most other trusts and 19 in the expected range. So
Yeah,
green better.
When I was going down the following slides, 8 onwards, there was more than 9 scoring better.
1, 2, 3, 4, 5, 6, 7. Oh, I've lost one now.
I think there was 4 on that very first slide that you showed.
Oh no, they're the section scores, so I haven't included those. These are the question. Donut is the question scores.
Yeah.
And this one is your section scores.
Right. Okay. Thank you.
Yeah.
Thank you.
I know, because I did the same thing when I was counting up to put the donut square in.
No, thank you. It's always worth clarifying. So thank you. So we'll go to questions now, if it's okay. So Francis, first to you.
Thanks, Michelle. Thanks, Sharon. Just to say, really well done. I think Mike Cook's already put it up. Really good health survey, significant improvements. So well done to all of the team on the time and effort and work you've put in. Really good to hear that you're carrying on with the same plan, because it seems to be working well. And the question I wanted to ask, you're not going to answer because you've just told me. I was going to say, how are you going to celebrate your success? Because that seems to be what we should be doing. But you then said in your speech that you weren't going to tell us that because you wanted to surprise people.
Okay, thanks, Francis. Come to Mike Cook next, please.
Just to endorse that and reinforce, despite Halo and donuts and everything, I recall seeing the first community mental health survey for this organisation in 2015 when I first joined, and it was the worst one I'd ever seen. So we have made massive improvement here, and everybody should be congratulated. It'd be nice that the board could mark it to, as well as the surprise that's coming in 2 weeks, to the likes of Kwame and Paul and others, you know, through Lynn, who are leading this, because this is a very significant change, and Quality Committee will be very pleased to have a look at this with you and the work you're going to continue. Let's lock it in, let's move forward, but let's celebrate it, because this is a very good survey.
Thank you, Mandy. If you wouldn't mind, when appropriate, if you could just share with the board the celebration, and if the board can endorse or help in any way, just let us know. Michelle?
Thanks, Jenny, for the excellent presentation as usual, and it is good to get it a little bit earlier. And thanks, Mandy and John and the team. But I think you touched on it a bit. Thank you to the divisions as well for the work and the staff that they do. Obviously, this is essential work. What service users tell us, that's one of our that is the most important thing that we're here for. I do think it shows the benefit of linking it into the quality improvement work and making it a continual process. And not just having action plans per result that comes through. And I think it shows that the trust approach is working. And as Mike said, when we arrived in the organisation, that it was the worst that we'd seen, and we have significantly made improvements year on year. And don't forget, we have had positive ones. It dipped a little bit last year, because if you remember, the year before we got one of the best in the country. So it's actually great to see the significant differences. But I think what's important for me is the areas that we are looking at are the ones that are improving as well, which is really positive. So thank you to everybody, and it is a continuous process. And I was going to suggest if Mandy could share how she was going to reward the staff. If you can let me know, Mandy, I'll share it with the board as well. But I want to link it into the ongoing reward process that we're doing for staff as well, to make sure it all links together. So that'll be really good, and I think it's essential that we do that, and we constantly try and thank staff and say how valued staff are at every opportunity that we can. So I think that's really important. But great stuff, great presentation, great work by everybody, good team effort, and just show how much of a community we are, and we are making a difference to people's lives, which is what we're here for.
Thank you. Mike Smith?
Yeah, I was just going to say that I attended the research conference and I did listen. And that COVID effect, actually, corroborated what was being said about the questionnaires and the gratefulness factor. And I was just wondering, Jenny, whether any of your questions had altered in order to avoid that trap about asking for general satisfaction and going much more into patient experience. I think you have captured it, but I just wondered what your comments were.
Sorry, on the questions from the questionnaire, sorry, whether the changes
I was
being made.
just wondering whether you'd been through every single questionnaire on that. I mean, you weren't at the research conference, but what they were saying was that questionnaires tend to ask whether patients are satisfied with their care, and that tends to come over across as asking patients whether they are grateful. And I just wondered how much effort you put into looking at that, or whether that was something that was just an aside.
It's not something that we've sort of looked at in terms of the questionnaire design. That very much comes from the CQC, but I would anticipate sort of with so we do tend to go for satisfaction rather than gratefulness in other questionnaires that we design and work on. It's an interesting point. I don't really sort of quite know how to answer that, I'm afraid, Mike. But all I
and like I was saying, asking about satisfaction can be interpreted as asking whether you're grateful. But I'll leave it there. I'm not an expert.
It's interesting because I think that's probably where you'd want to look at your free text comments. That's, you know, you can often then see people say, you know, I'm really grateful for the help that I received, and that maybe gives a little bit more insight in free text comments. Certainly in other surveys I've seen, I'm honest, it's usually sort of like cancer surveys. People talk about how grateful they are for the care that they've received. So that might just give you a little bit more flavour to whether it's gratefulness or satisfaction.
Okay, John?
So it's interesting, isn't it, the COVID effect theory from the CQC. So I suppose we'll await in time to see actually the statistical basis which they make that claim. But the bottom line is this is benchmarking against 50 other trusts, isn't it? So you know, that same COVID effect will have applied to everyone. So we will still benchmark in the same way. It'd be nice to think that there was some positive appreciation from the general public going forward with regard to the work that we do. But look, let's just bank that as opposed to taking a deficit-based view of it.
Absolutely.
Thank you, John. And we'll close it there, this discussion. But thank you, Jenny. Really comprehensive, always a good report. And it's always a pleasure to have you at the board to come and talk to it. We really do appreciate your time.
Thank you very much. Just personally and professionally, I'm absolutely delighted and over the moon for the trust as well for your results. I go to so many, and you can tell which ones you know you're going to see improvement in. And I can definitely see over the past few years and your engagement in the process, and it's absolutely well deserved. So yes, thank you for letting us help you do that.
That's really kind. Thank you. We appreciate the comments very much. And Mandy, thank you as well for coming along and co-presenting, but also for all the work that you and all the others do in the background. So thank you very much. Thank you both.
Thank
you. Bye-bye.
Thank you. Bye.
So if we could please move back to item 9, which is the performance report, and it's page 53 of your packs, if that's okay.
Sorry, Chair, Alison, I think Alison Flack's here for FEAM to speak up.
Oh, she's...
Alison, are you here?
Alison?
I can sort of... I was just wondering, because Alison's coming back later as well, Chair. Is it okay if we take Freedom to Speak Up and then maybe have a quick 2-minute break? Is that all right? Do you mind?
Yeah, no, that's fine. So Freedom to Speak Up is item 17 and it's page 146 of your packs. So
thank you. It's just as I say with Alison coming back.
No, that's absolutely fine. Sorry, I didn't realise Alison had joined us yet. Alison, welcome to the board again. It's lovely to see you again, and thank you very much for your report. Michelle, do you want to introduce it?
Yes, obviously it's agenda item 17, as you say, Chair. Thank you, Alison, who's our guardian. As you know, I'm the executive sponsor. I feel very strongly about the Freedom to Speak Up process and the Freedom to Speak Up that we've got in the organisation. So, Alison, over to you.
Okay. Good morning, everybody. Thank you, Sharon. Can you hear me? Okay.
We can, yes, thank you.
All right, just double checking technology. Thank you very much. Just a progress update really from the Freedom to Speak Up Guardian and the work that's been going on across the trust. Just in terms of the key points that I wanted to highlight to you is the first one being the National Guardian's Office launch of the training package, which is in 3 modules. The first one is for all staff, and we're hoping to roll this out from our induction. So all new staff will see the Speak Up training, which is really good actually. And then we're looking at how we roll this out across the rest of the organisation. And Michelle has asked me to attend an executive management team in January to look at how it will go in the training diary, but to look at how we can actually get this rolled out across more of our staff groups and whether we need to make it mandatory training. As you'll all know, we had our National Speak Up Month in October. So there was lots of activities, virtual activities going on across the trust. We were able to go and meet with the Senior Leadership Forum, which I think was a really good opportunity to raise the role of the Guardian, but also moving it that step forward really to start to talk about how managers need to develop a culture of listening and what behaviours that they need to be modelling to allow staff to feel comfortable to raise their concerns at any level within the organisation and feel assured that they're going to be listened to. In December, I'm going to meet with the patient staff champions. So thanks very much to Mandy Dawley for enabling me to be able to do that. And I hope that we'll be able to share the training with them as well, because they're actually out on the shop floor. We've got a number of patient staff champions now. And if they could help us to promote the role, but also that sort of changing culture, that's going to be really good as well. In terms of cases, you'll see that we had a slight reduction during July, August and September. That is starting to rise a little bit now. The main areas where we've had concerns raised has been in the children and young people's services around the inpatient and community. And as a result of the concerns that was raised, Lynn, in her role as Chief Operating Officer, has commissioned 2 reviews. One of those is very close to being closed, and the other is well on its way. The other area where concerns were raised was the mental health response team. We're still seeing a number of HR concerns coming through our route, but we are quickly able to signpost those on to HR colleagues, so that is helpful to be able to do that. And we have had some concerns raised in response to COVID-19 and working arrangements, and we're still communicating that through our regular newsletters and things. That's just a whistle-stop tour, really, Sharon, just to give the board an update on the work that we've been doing in the Guardian role. So I don't know if anybody's got any questions or comments that they want to ask me.
Thank you, Alison, and thank you to you and the deputies for all the work you do. I know we meet on a quarterly basis. I'll just come to Peter first, who, as Senior Independent Director, is obviously very closely aligned to the Freedom to Speak Up work. Peter.
Oh, thanks, Sharon. Yeah, I think Alison and the team, basically, the fact it's all virtual these days, it's business as usual. We've had our catch-ups, and I think the culture of the organisation now, compared with maybe a few years ago, has improved. So I think, although there's 1 or 2 more cases coming through, I see that as a positive. We had the Freedom to Speak Up month in October, and I think perhaps part of that is because of the communication plan around that. So I think it's working very, very well. It's not working any less well because of the situation with remote working. So I'd just like to thank Alison and the team for keeping up the good work.
Thanks, Peter. Hilary.
Thank you, Chair. Alison, I've just on the report, it says the main categories, patient safety and quality of care. I do get concerned that we have some sort of parallel running, if we're not careful, where we've got, all this information we've got around patient safety and quality of care is obviously held in the DATIC system, and that's where we pull the themes, trends, etc. from. When people approach you and you put it into that category, do you also ask them if they've done a DATICS?
In the main, yes. I mean, in some respects, a couple of concerns we've had is there's been a culture of where people haven't been encouraged to do day text, but we're seeing that is increasing, Hilary, in some of the areas. But that's something we can add into our process so that we make sure that we are saying to people that they need to do a day text. But I haven't seen where if it's specific examples, then we would always say, can you make sure that a day text is done or that they're supported to do that?
Yeah, thank you.
Thank you for that, Hilary. Lynn?
Thank you, Chair. So just on that point, Hilary, the 2 investigations that I've commissioned, I've deliberately included you in the content of those where any clinical safety issues have been raised. So, and also that, you know, one of my perspectives on those is to ensure as well, like Alison says, that datexes have been completed where that's been appropriate. So it's any of the cases that I'm seeing, I do alert you to them.
Yeah.
No, thanks for that, Lynn. Anything else on that? No, Alison, as I say, thank you to you and the relatively new deputies now. They've been in post a little while. I really appreciate all the work you do, and it is genuine work. And I know you came to the staff governor meeting that I have with them, and I know the feedback from them is very positive, and they're very constructive in their ideas and input.
Yes, they have.
But overall, the feedback is very positive. So thank you very much, and thank you also for joining us again today.
Thank you, John. I just wanted to note as well, in terms of the Peter's point about the numbers and how we're comparing nationally, we haven't actually had back the National Guardian's Office numbers because of the pandemic. They were late in gathering the data, so my next report will include how we compare nationally. So I just wanted to put that to the board as well.
And can I also thank Peter and yourself, Chair, because obviously we do meet regularly. I mean, I meet with Alison very regularly and go through every case, but I think that the non-exec contribution is really helpful and supported and really welcome. So thank you for the commitment that you put in as well to it, because it's a really important area.
Thank you, Michelle. So thank you. Can I suggest we just take a 10-minute break and we reconvene at we'll say 11:22 on my screen. So 10 minutes and we'll be back at 11:22. Is that okay, Adam? Welcome back, everybody. If we could start with item 9, the performance report, which I think is starts at page 53 of your packs. Pete, over to you.
So thank you, Sharon. So this is the performance report as at the end of October, so month 7. Reports in the usual format, presented using statistical process charts. And just to reiterate, we started shading the graphs from when the COVID pandemic started. We've included commentary for the key indicators on the front sheet, and we've also put the waiting times trajectories as an appendix to the report. I guess one item I probably would like to draw to the board's attention, and it's not actually in the body of the report, but cash, which has been outside of variation, is now in normal variation, because we've obviously been operating in the additional cash regime for a number of months now. At some point that will be clawed back, and then we will fall out of variation. I guess I'm just warming the board up to the fact that cash will fall outside of variation at a future date. And I think if I stop there and we go straight to questions, Chair.
Thank you, Pete. Any questions on the performance report? Peter?
It's not really a question. It's more of an observation, really, just on the dashboard, because we have got an awful lot of units not too far off 100% full, which it is what it is. But when we come perhaps to next year and there's much more demand because of what's been going on, I just don't know where we're going to go for bed capacity within our own services and perhaps within the system as well. It's something which is concerning me, and I don't know if you want to take it now or perhaps in the COVID reports, but.
Should we pick that up now, Peter? Because I think it links into the demand planning, the work that we're doing, and also the system work. And Lynn, what we're doing at the moment from a COVID point of view is looking at the surge plan across both geographical patches and then the ICS, because each of our organisations, each of the provider organisations have got their own surge plan. So we're bringing those together, or I've asked for them to be brought together as part of the patches, but then overarching the ICS, and Lynn's helpfully leading that work with me across the system. But one of the things that we have looked at, what is our flow? Because our flow is very good usually in the acute system. But obviously we've got the COVID secure areas, so hopefully they will not last forever. Hopefully with testing, vaccines, etc., we can put capacity back into the system. But we have put some contracts out into the private sector. Now we do need to look at that, and this is fairly hot off the press because of the Chancellor's announcement today and the announcement that mental health is going to get about another £550 million. Some of that is going to come in straight away for discharge to access, which will be in order to facilitate discharges, but not necessarily into the independent sector. So we've got to look at that, but we have at the moment contracted, and I'm going to pass over to Lynn, particularly we have contracted with other providers with hopefully not massively geographically far away, though a bit further away than we would like. So it gives us actually the bed capacity. The other thing the system have asked for the system to do, and we're looking at the moment, is just exactly how many beds we've got there. One, because it will help our inpatient redesign work. Because in order for me to sign it off in my ICS capacity, I want to be really assured that we've got enough beds in the ICS. And that includes Foss Park, so we would need to take all those into consideration. So that's more longer term linked into the inpatient build, but at the moment, to help us over this initial hump, we have contracted for extra beds. But Lynn, do you want to pick up the detail?
Yes, thank you, Michelle. So as Michelle says, I'm working very closely with our other local mental health, particularly providers at the minute, because it is the pressure on mental health beds. Interestingly, our community physical beds are flowing very well at the moment, which is great. But mental health is the pressure as we anticipated that it would be. So we are developing what's being called actually a super surge plan, so that we can really understand at any moment in time what the pressures are across those providers in our ICS, and then obviously a plan to actually work collaboratively together to mitigate those risks where we're able to do that. So that means that there is some feasibility of mutual aids across providers, which we've already started to work on anyway at the beginning of the first wave. So it's building on that work that's already in place, but actually augmenting it, as Michelle says. So it's recognised nationally that the mental health pressures, particularly in relation to beds, will exceed capacity, and that the independent sector is identified as needing to support with that. So we have been in a position as a trust where we needed to do that a couple of weeks ago, and that's because two elements. We were already in a position where we were needing to use some out of area provision, but also because we had some outbreaks across our inpatient areas, as have the other trusts too. And obviously that's directly correlates to the level of infection, particularly in Hull, and the rise that we've seen there. So that has really supported us. Interestingly, our occupancy is declining at the moment. So when those wards actually are now, as they are starting to reopen, we have actually got empty beds, and our flow is steadily improving again at the moment. So whether we've reached the peak of this current surge, I think that remains to be seen. The view is that that's probably still a week or so away. But obviously we want to prepare, we're optimistic with the introduction of things like lateral flow testing, potentially the COVID vaccine as well, that will have an impact on our overall system. But as Michelle says, we're really trying to meticulously understand, what that means in terms of future. And as Peter, I think you've already recognised, that potential ongoing impact on mental health demand as a consequence of COVID, directly and indirectly. And as we all know, the economic impact on our particular group of mental health service users is historically significant. So taking that into our planning very much as well. So also, as ever, we don't just look at the bed element of our services, making sure that our out of hospital pathways are working well, which is, I think, really important that we are in that fortunate position that we are rolling out the CMHT transformation. Obviously, if we can actually get that support enhanced in primary care, then that should really, the whole driver of this programme of work is to put more recovery focused prevention work at the primary care end that will ultimately support our secondary and crisis care pathways. Talked at the board before, obviously, about we do recognise we've got a deficit of older people's functional beds. We have contracted with Navigo, interestingly, to support us with that in the short term, but again, continue to look at the out of hospital pathways to support with that too. So it's a whole system surge piece of work that we'd already done ourselves as a trust, but now really building on for the reasons that Michelle says, as an overall system, to be as well planned as we can be for potentially that increase in demand over the coming months.
Thanks, Lynn. Does that answer your question, Peter? Yes. Mike Smith.
Thanks, Chair. Just looking at page 66, which is the friends and family test. I just want to be clear about what we're measuring here, because I think we're measuring friends and family involvement, which is what's on the graph. But the description is the results of the overall surveys completed where patients felt they were involved in their care. So that's my first point. Then I've got a question. Am I right that it's about friends and family involvement, not patients being involved in care? Page 66.
John, could you?
Thanks, Mike. I'll need to come back and clarify that to you, because to be honest with you, sometimes I look at this the whole time and get a little bit confused. But there is one challenge.
Let's leave that there then. But the next one is that looking at that graph, we've got a 5.2% decrease. We've got a decrease in trend. Now that you could interpret as being bad, but if I'm right, it's very positive, because if it is about friends and family involvement, that peakiness, say in July and then again in September, mark different phases of the lockdown. And I think it's a tremendous performance if we're still achieving 86% of what I think is family involvement in the current times. So that's all I wanted to say.
Thanks, Mike. There's 2 points about that between the GP data which we collect and the inpatient data which we collect. And the GP data we collect in bulk, whereas the inpatient data has been trickier to collect because of COVID infection control. Although we're going back to do a validation exercise, Mike, around the inpatient stuff to make sure we have captured all the forms that people think they have sent in. So this data goes up and down. I'm always wary about saying it's a trend in terms of positive or negative. We do know that a lot of people, anecdotally, we hear the stories, are struggling through COVID. Lots of people feel that they are getting a good service, but you can see that from the longitudinal survey that we just discussed about 20 minutes ago. But what I would say, this is a work in progress in terms of continuing to get more and more feedback and then use the feedback gainfully. But month by month, I'm always cautious of pressing, celebrating too much or pressing too much panic buttons either.
Okay, thanks, John. And we'll just clarify that outside the meeting if that's okay. So that's helpful. Dean?
Sorry, can I come in there, Chair, because it's on this subject? All right, so I've got my hand up. Yeah, I mean, we've got the live dashboard for friends and family, but this is particular questions that the patients themselves fill in to say, do they feel they're being involved in their care? I think for a couple of months now, we've said that the deterioration is due to primary care, I think, which is what we have done this month, because, I think before it was around particular vaccinations and health visiting vaccinations. I just think, given that the slight statistical variation, it would be helpful, I would suggest, if we could ask Quality Committee just have a look at a bit more detail at it. And then maybe could bring back at the next assurance report just what their thoughts are in relationship to the Friends and Family Test. Just when you look at the SPC chart, I think it would be helpful if we could utilise the Quality Committee, looking at Mike, if that's okay as chair.
Okay, Mike.
Yeah, and I think if John and Mandy want to bring that when the time's right, that's fine. Yeah, absolutely.
Thank you.
Is that okay with you, John?
Yeah, can I just add to that? We sort of bring regular comprehensive 6 monthly reports into Quality, where we look at a whole range of patient survey data, including the inpatient, the community survey, the friends and family, and also the patient reported feedback on our doctor. So happy to take a look in this. I think the problem sometimes with these dashboards is, do we want to sort of think about the data on a longitudinal basis over a year and draw the conclusions, or look at it month by month? So we know that in certain places we'll be performing better than others, and that's about sort of working with the teams and the services themselves to understand that. But happy to have that conversation, Mike, with yourself and Mandy back in Quality Committee.
Thanks, John, and thanks for the suggestion, Michelle. Dean?
Thanks very much, Chair. Mine was just a question on the trajectories. I don't know if that was going to be covered separately, so I don't want to cut across it if someone's going to give an update at all.
That's fine.
It was just I know we've been talking about trajectories for some time, and the paper talks about something coming to the Quality Committee in December, but just the trajectories that are attached, I just didn't understand the status of them really, in terms of where they'd come from. They seem to be sort of laid out almost as a sort of ideal position of what might happen. And I guess it was just sort of flagging maybe a bit of an expectation of something sort of more detailed and robust for us to consider in December at the Quality Committee about specific actions that might be taken, the sense to which these are sort of got managerial oversight, etc. So I just wanted just to pick up the sort of context of those particular trajectories here.
Len?
Chair, can I just pick up on that if I may as well? That I had a question around that, and I wanted to understand the sensitivity analysis around it and the realisms, because I think that's kind of where Dean's coming from. There isn't any sensitivity analysis to say, well, if this happens, this will happen. So, plus or minus 10% variation, what effect does that have on that trajectory on just about all of them?
Yeah, and I think, because one of them, I think it's a 4-year trajectory anyway, isn't it? So again, it's just the quality impact. Lynn?
Yes, thank you, Chair. So in both of those respects, so these have been developed obviously directly with assistance from BI and the service areas. So, and absolutely, the intention, and the paper's already prepared, is to bring these trajectories again to the Quality Committee at its next meeting, and with it we'll have the individual action plans for each of those service areas. So absolutely, you can see the detail of the action being taken, and that will include those sensitivities, Francis, that you raise.
Thanks, Lynn, that's helpful. So we'll make sure that it does go on the agenda of the next Quality Committee, and we'll also, Jenny, if we can just outside the meeting make sure for the non-execs who are on that committee that they get that paper. That'd be useful, I think. Thank you very much. Francis, did you have any other questions?
No, Chair, thanks.
Okay, anything else for anybody else? Can I just ask a couple on the quality dashboard? It's just looking at there's a couple of high sickness rates, which I suppose not to be unexpected completely, but I was just looking at the one for stars, for example, up at over 20%. Is this COVID related or is this something else? And then PQ is very high as well. Lynn, perhaps could you help?
We look into that?
Sorry, sorry, I was on mute. I picked it up. PQ is COVID related.
Right.
Stars is a mix of things. It's mainly impacted on the move of the team from Hawthorne Court to Townend Court. There's some issues there, I think, around that move. I've had a full breakdown of that sickness because obviously I picked that up as well when I got this dashboard. It does stand out, doesn't it?
It does.
But this is the month that team moved across into Townend Court. So it's all been managed. It's all appropriately being managed. So I was quite reassured by what the team were doing there with that team.
Thanks, Hilary. That's helpful. And just one more thing, and forgive me, but on PQ, the number of incidents of physical violence and aggression is at 96. And I haven't looked at previous board reports to see what level we normally get, but is that a usual level for PQ?
We've had quite an acutely unwell patient on there that was creating 6-7 incidents a day, each one being documented, because we do always ask that they document each one individually rather than sort of at the end of the day, because we would lose the numbers then. So that's what that contributes to that high number, is that one patient that's actually moved now. So we should see that come down.
That's fine. It just seemed a bit high to me at the levels, and as I say, coupled with high sickness, I didn't know whether they were linked, if you see what I mean. So no, thank you for that. Okay, thank you very much. Then if we could move on to item 10, which is the finance report, Pete.
Yeah, thank you, Chair. So this is the Month 7 finance report, and this is the first month I'm bringing it to the board where we're operating in the new finance regime. So just for clarity, we're no longer operating in a process where we can retrospectively claim for COVID and top up to break even. Instead, we've been given a fixed allocation for the remainder of the year for both elements, and we're expected to live within that as we picked up in the board plan last month. I guess some of the key highlights I pick out of the Month 7 before we move to questions are: we have recorded a break-even position after we exclude impairment and donated asset depreciation, so that's what's been asked of us. And I guess I would also pull out, some of you will have noticed the mental health overspending month. That relates to the reprofiling of the CMHT project. We talked about that earlier in the board, and we've now aligned the finances to the revised recruitment trajectory. Year-to-date COVID costs are £9.5 million. I can say that our Mum 6 claim has been signed off by the regional team, so we're just waiting for clarification from the national team now. And we remain in a strong cash position, notwithstanding we've got the additional cash that's bolstered us at the moment. And I think if I stop there, Chair, and I'm happy to take any questions on the report.
Thanks, Pete. Mike Smith.
Thanks, Chair. Just a detailed question on page 103. It's the secure services paragraph 234, and it's an unfunded enhanced package of care. And I'm just wondering whether that's us being good in the standard of care we give in the knowledge that it's unfunded, or whether it's been some care that we've given that the commissioners have refused to fund because we've done something wrong.
It's probably, I'm not going to say it's a combination of both, Mike. At the moment, the current finance regime is that we can't invoice commissioners for enhanced packages of care. So normally we would agree an enhanced package of care, and the one we're talking about today is an existing package of care that was funded last year. So under normal contracting regime, we would be invoicing that to NHS England, but because we're operating on the block arrangement with our allocation for the last 6 months, that funding doesn't flow, but it will be picked up next year should we return to normal contracting.
Okay, I suppose what I'm asking really is it's over £100,000, so it's not insignificant, and I'm just wondering whether we should put more scrutiny into it or whether we just shrug our shoulders really.
I think for now it's quite a complex, just to support Pete, it's quite a complex case is this, and I am aware of it. And at the moment I'm not going to try and recover costs at the moment. I will do when we've sorted out the complexity of the case. Then irrespective of the financial regime, then we'll start to look at recovery of the costs.
Yeah, thank you.
Okay, thank you. Anything else on that? Pete, can I just ask, and probably you've covered this before, so apologies. Can you just explain the finance technical items variance to me, please?
It's double-edged, Sharon. So within the finance tech, we've got the BRS provision that we've talked about previously, and we've also got the BRS profiling on the plan. So you've almost got a negative profile year to date for the BRS, but a positive BRS provision. So it kind of is a double whammy why it's a significant number in the report.
Okay, thank you for that. And I think I mentioned it last time, but I think in the appendices, Westlands needs changing to West End.
Apologies, Chair, I missed that.
No, that's fine. Anything else on that? No, thank you very much. If we could move on, please, to item 11, the Charitable Funds Committee Assurance Report. Mike Cook.
Good morning again. Just briefly, Charitable Funds Committee is meeting regularly. This covers the meet we had in early November on the 3rd and the minutes from the 22nd of September. We did take one of the audit committee recommendations about the £100,000 being any expenditure from charitable funds. Above that is a board reserved power, and I think there's something in the standing orders paper. There's also a 25k one, which again we're very happy to report as a significant expenditure. We did also ask for more ideas for use of the NHS charities funding, and Lynn has organised for Victoria and Christina to attend the next staff health and wellbeing group, which we see as the key beneficiary and place where we'll get the right ideas to have the impact with those funds. And I suppose we were very keen that Whitby appeal is mobilised, the hospital appeal, and that's beginning to look good. We also had a look at Bridlington as possibly a next area we might look at, and also the campus reprovision. We want to have a good look at, plus enhancing the Christmas offer, enhancing that for patients and staff amenity, with the circle of wishes and grants and everything that's going on. So don't know whether Pete, Steve or Peter want to add anything, but it was a good meeting, but perhaps a shorter one than some.
Thank you, Mike. Pete Beckwith has sort of existing exec lead.
As existing exec lead, I thought it was a really positive meeting. We had a useful presentation from Andy about how we could support the Bridlington community, but I think as a committee, we asked for Andy to come back to us with a little bit more meat on the bone of what was the art of the possible. But I just echo Mike's point, a really positive meeting.
Steve, as the new exec lead, is there anything you want to add?
No, I just echo that it was a positive meeting, Sharon, and yeah, good. Looking forward to going forward.
Brilliant, thank you.
I think just to add, I was quite pleased to see the Bridlington thing. We just wanted to make sure it was anchored in the right order and that Natalie and others were involved with it. So I think Natalie's going to come and join a further presentation when it feels appropriate. But I think the Smile team have got the message that we want to see appeals happening because we think that's how we get the best out of the relationship. So good, thank you.
No, thank you all for that. Any questions on that? No, thank you. Thank you for that comprehensive report. If we move on to item 12, which is the Mental Health Legislation Assurance Report, Mike Smith.
Thank you, Chair. I felt it was a really good and enjoyable meeting, and I felt there was a real team feeling to the meeting, and that manifested itself. Not only did we get representation from East Riding, we also got representation from Hull, and we've got 2 trainee doctors attending. Some fantastic work on the MAPA, working in partnership, that's the multi-agency public protection arrangements, the work with the police, with the right person, right care. And then a bit masters of our own destiny, the internal audits that we've actually decided on the priority for internal audit, which is compliance with consent to treatment. So it really felt a sort of togetherness in that meeting. I just hope others felt the same.
Thanks, Mike. Lynn or John, do you want to add anything? No. Okay, thank you. Any questions on that paper? No, thank you very much for the report. We'll move on to item 13, the Workforce and Organisational Development Assurance Report and September minutes, Dean.
Thank you very much, Chair. This is the meeting from the 18th of November. So as usual, I'd just like to thank Jess and Steve's team just for turning this around so quickly for us, so close to the board, so we could go to the board meeting. I guess unusually, we've got an item to escalate to the board from one of the control risks, which I'll come back to. I'll just say it was a positive meeting again. We highlighted the work of the care groups that have been coming and giving sort of presentations on what they're doing in staff survey. Really good presentations that we got there, both in terms of looking at the positive outcomes from last survey results and also the work that people are doing. And I think really interesting to see and express so clearly from that team about an understanding of the impact on how staff feel about the care that they provide. So real sort of encouraging presentation. We had a new sort of revised workforce insight report. So over a period of time, it had been expanding and we'd got more and more detail, but the committee were feeling more and more assured about the work that was ongoing. So this was an edited down version to allow us to look at some broader strategic issues. That was well received by the committee, and we'll obviously continue to iterate that so that it works for everybody involved in that. And then we also had a look at the recruitment and retention areas and the work that's ongoing there, and noticed some positive progress that had been taken forward. But just coming back in terms of the escalating item, this was really just about the health and well-being of staff. And just want to emphasise here, the reason for asking it to be escalated wasn't because there was a concern in the committee that the organisation wasn't doing enough. Quite the contrary, in fact, we appreciate and we understand a huge amount of work that's going in to support staff in terms of their health and well-being during the COVID period. I think what we're sort of recognising is that sort of 9-10 months now into this, that the impact is sort of longer term than perhaps people had anticipated back in March. We know it's going to continue for some months yet to come. And it was just the idea of getting the board more cited on the sort of consequences of that, and recognising that as a sort of rising risk within the organisation, and both in the immediate term and longer term, what the consequences of that might be. So this may be something that we might touch on maybe in the risk register, but it might be worthy of a broader sort of board discussion. And also to emphasise, we do recognise what front-line staff are feeling through the course of COVID, but we've seen through the board today just some of the demands that are on our senior managers and the senior team as well. So in addition to trying to manage an organisation with all the constraints that we've got during the COVID period, and then doing things like a flu campaign, lateral flow testing, sort of rollout of risk assessments for people, preparing for COVID vaccinations for staff, all of those require an enormous amount of work, and we recognise that sort of impact on the senior team as well. So it's just flagging it in that regard, as I say, not as a remedial, we're not doing enough, but more about it being centre as one of the risks for us. I don't know if Mike Cook wants to add anything. He sort of picked up in the meeting whether I've captured that risk right there. Thank you.
If I may, absolutely. We noted that the current risk for that particular, the score for that risk was 16, and the target risk is 4. And we had a debate about, and we knew it's absolutely scored right, and that's the gap we're trying to keep an eye on and hopefully close in time. But it's a really tricky one to get across. So that, I think there was a lot of empathy in the non-exec contribution to that item, and that I know that was well received. And anything we can do to keep the really good communications, the sense that we've got some momentum. Really delighted to hear Michelle feeling morale actually is the game changer, the vaccine. We know it's on the way. Is that a good thing? We can discuss that no doubt later on, but it was a very good discussion. It was a sophisticated one based on a really good update and insight report from Steve.
Thank you, Mike. Thanks, Dean. Steve, is there anything you want to add before I take questions?
No, I guess kind of hard to follow both of that. I thought I just echo it really. I thought it was a really good meeting, and hopefully we're creating that space to have the kind of conversations that we had, and has just been evidenced there. And I think the more we do that, we'll keep going from strength to strength. So yeah, I think it was a really positive meeting, and I think we also, just worth adding as well, we've got a rotation for our staff network groups who also come into that group. So we had Grace from the BAME group. We'll have our LGBT staff group attending at the next one, and I just think it's fantastic that they've got exposure and feed into that process that we're talking about workforce issues. They bring a different insight to it for all of us. So it really feels like an evolving committee.
Okay, thank you. And I know this is something Michelle's picked up at, well, various meetings for months really, and flagged it to the board. So, well, perhaps Steve, you, me and Michelle could perhaps have a discussion about a broader discussion as suggested outside of this meeting. And we can obviously bear in mind the comments that have been made when we come to the risk register. As you say, Dean, that's on the agenda here. But no, thank you very much for flagging that. And it's great to see the governance process working as it should. And thank you for turning around the report so quickly, because it is a very tight timescale, so it is appreciated. So if we can move on, please, to item 14, which is the Audit Committee Assurance Report. Peter.
Okay, thanks, Sharon. So we had an Audit Committee on the, I think it was the 2nd of November, early November anyway, and it was a very good meeting, I thought. I think there are just about 4 items, perhaps, which I'll highlight. I'll put them at the bottom of the report. We had a very good level of internal audit recommendation completion, follow-up clearance by the team again. From a couple of years or 18 months ago when it was a poorer rate. I think in this meeting we found out, given assurance, that there was a good level of completion of these matters. And I think from the prior year audit recommendations, there were only 2 out of like 107, I think, for last year that were actually moved date. All the others were completed on time or yet to be completed, but within the timescales agreed. So I think that's come on an awful lot in the last year or 18 months. So I congratulate the team on that. We had a really good information governance annual report. Lisa came along to the meeting. Lisa Davis came along to the meeting to give that, and we got a lot of assurance from that. 1 or 2 minor tweaks, but I think that'll be available on the intranet pretty quickly for everybody to have a look at, and the accolades as well that Lisa and the team have had in the year have been well deserved, and we were very pleased to receive that report and ask them to keep up the good work. Audit Yorkshire joined us for the first time. A couple of things there. I think there were 5 members of their team very actively involved and proactively involved with the meeting. It was as if they had always been there really, and they joined in not just on their own section but in other sections of the agenda as well. So I think that's a very positive move that that we've managed to make, to push it over to them or to award the contract to them, and I think we'll get a lot of benefits from that buy-in, extra buy-in that they seem to have. One of the things that we discussed with them as well was for them to facilitate an audit committee effectiveness review, and we haven't mapped that out entirely yet, but probably sometime after the next meeting, once they've seen how the next meeting works as well, we'll commission a review, probably in March, April time. Might be able to do it in person, but anyway, or Teams, whichever, and they will be able to assess with their expertise and with obviously colleagues, do surveys, etc., to how we're doing and how we might also improve on that, which we always want to do. So that was very positive. I'd just like to say on the internal audit reports, the expenses one was the one that was slightly less assurance. That was reasonable insurance, rather than all the others were substantial or good. A lot of that related to minor tweaks necessary in the expenses policy, and if you noticed in the workforce and OD assurance reports that the new expenses policy has just been agreed. So I'm hoping, I've not seen that, but I'm hoping that deals with the matters that the internal auditors raised on expenses, and we will. It wasn't major, but it was just tweaking it, and I think we'll review that. We're down to review that for the next meeting, just to cover that one off All the other reports were either good or substantial assurance. So unless anybody has got anything else to add, then that's the report.
Thank you very much, Peter. Pete, do you want to add anything?
I think it was nice to have Audit Yorkshire at the meeting, Chair. You know, I think it's fair to say that they've transitioned really well, and I think they will add value, and you know, will be a good addition. You know, Peter stole my thunder on the travel expenses policy, addressing the concerns that were raised at the committee, and I'd like to thank Lisa for attending, because it was really good to have someone from the IG team attend and present the report, because you get that level of assurance. And also, I'd probably just like to thank Ian and the work of ODG on progressing the audit recommendations, because it's really positive to see that and maintain it as we have done for the last 12 to 18 months now.
No, that's great, Pete. And I think for those of us who have attended the odd one or two audit meetings, we can see the difference in those, and the new policy and process you've got for following up the recommendations has really made a difference. So yeah, well done on that. Any questions for Peter or Pete? No, thank you very much. We've already covered obviously item 15, so we can come to item 16, which is the COVID report. Lynn, thank you once again for this very comprehensive report. Obviously, it covers an awful lot of work that's going on and issues. We have read it. It's on page 134 in your packs for those who want it. So Lynn, over to you.
Yes, thank you, Sharon. I'll just pull out some of the 2 or 3 of the pertinent points, really. So this report obviously describes the introduction of the new national restrictions that took place on the 5th of November. Alongside that, the NHS also raised its instant alert level back to its highest level of level 4. So obviously, from our point of view locally, we have been having a particularly sort of challenging sort of past 2 to 3 weeks as well, as those pressures described in this report continue to rise, particularly in relation to obviously the infection rates across our region, which is high overall compared to the national position, but obviously particularly in Hull. So we saw a consequence to that in increase further in our staff sickness absence during the period. I'm optimistic, she says slightly cautiously, that hopefully that did continue to rise to the end of last week, where for the first time our overall absence just tipped over the 10% mark. Now it has reduced again since then, so hopefully that will continue to happen. But obviously that created pressures for us operationally, particularly in our mental health inpatient area, which we've touched on already today. So our requirement to utilise out of area beds, although it reduced in this report, has risen subsequently since then. Our view was, because we had prepared well for the national local alert system, the tiers 1, 2, 3, that our tier 3 planning actually did stand us in very good stead for the introduction of the national restrictions. So in essence, we really didn't need to do anything further. We'd already reviewed our policies around visiting, as you know, patients leave, those sorts of areas. So we were in a good place to respond to that. In addition, obviously, we have had a rise in the number of COVID positive patients in our inpatient beds. Our cohorting arrangements have continue to be in place. Since this report was written as a consequence of the increased staff absence, particularly the pressures in the mental health division, we have changed our cohorting arrangements from Hawthorne Court to move it to Millview Court. The reason for doing that was again about just managing the staffing pressures as effectively as we can. But I can assure you that all of our cohorting and isolation arrangements have been in place. We have seen some outbreaks. Those are dissipating now. That has led to some of our inpatient wards being closed to admission for the required period of time following our infection control guidance. Those wards are now starting to reopen. So actually our pressures are abating. So that's positive. Obviously, we've already talked about some of the issues that have been new in terms of making operational the access to lateral flow testing. We have done that very quickly. We were one of the early implementers full rollout of that is now happening, will be in place by the end of the next week or so. Staff have received that very positively. I think Michelle touched on that earlier, that has sort of given some assurance to our staff, a little bit of control where, you know, control through this pandemic has been difficult to achieve. We've had no issues with PPE over the last month, and we are preparing with our colleagues in Huft for the expected rollout of the COVID-19 vaccine. We've continued to work really well with our system partners as well, touched on the surge planning arrangements that we are further working on. But I guess for me, as ever, really a big thank you to our staff who are very resilient, and we are, as the risk we've touched on already, around sort of the impact of fatigue. It is there undoubtedly, but our staff continue to step up no matter sort of, you know, that the pressures are rising. So they have reacted, you know, very flexibly. We've had to redirect some of our staff from our community services to support our inpatient areas. Some of our Whitby staff have supported the position with Scarborough services. So as ever, a really good and big thank you to them. We couldn't do this without that flexibility. So a challenging couple of weeks, but it does feel like it's abating now.
Thanks, Lynn. That's really helpful. John or Hilary, is there anything you want to add before I go to questions?
Just add about the outbreaks. Yes, we did have quite a number of outbreaks. I know there was a report earlier on the board papers, and there's one going to quality committee about the outbreaks. 7 were reported, I think, earlier on in the board. Since then, we've had some further ones. So we're up to now, since the start of COVID, going back to March, April time, we've had 12 outbreaks. So an outbreak is two or more people that have got the same infection that are in the same place at the same time, sort of thing. That's how that works. One of them has to be a patient. So I know outbreak sounds terrible, but we are talking small numbers there. And we have got on top of it. They've been managed very well. And again, they're a bit of a warning shot to everybody about the PPE and about what they need to do to keep everybody safe. And it seems to have worked. And as Lynn said, we're getting more now to a position of getting these units reopened again, and really tight processes on there on PPE, reminding everybody of the importance of that. But it was very difficult, a couple of weeks that we've been through. When we saw the surge in Hull, we certainly felt it in our services as well and had to manage that through. But the staff have done fantastic.
Thank you, Hilary. John?
So just to pick up the lateral flow testing, Chair, I think first got the phone call 2 Fridays ago about it. And within a week, we'd rolled it out in a pilot to over 100 staff. And I'm really grateful for the work of Claire Jenkinson, who's the new deputy coup, who was a baptism of fire in the trust and managed to sort of work right across sort of HR, clinical teams, clinical systems. So we got this out and running. Within the second week, we pretty much rolled out to 2,400 staff. We put in a request to the centre to be able to give this to all of our staff, because I think that was the original expectation of this. We've had incredible take-up of webinars from staff in terms of getting involved in this, and very, very positive anecdotal feedback. The one piece of the process that we're really having to work on is updating and increasing the amount of self-reporting. So you're basically given your own vaccine kit and you have to self-report. Now, we've got a web-based approach to that. So it's like anything else, with all the competing priorities going on at the moment, we're encouraging our staff to report the positive and the negative tests. Is a piece of work, but we're kind of thinking once we get the flu job done in the next sort of 10 days or so, we can start to focus on the lateral flow testing. We've had a small number of tests come through positive, but that's the benefit of the programme, so we can support our colleagues, isolate them, protect their families and friends, but likewise protect their colleagues and patients, particularly in the ward or clinic scenario. So this is a real benefit for us, and we were fortunate to be in one of the early waves of trust. So, and the key thing for us has been sharing some of the lessons. So that's been really positive.
Thanks, John. Michelle? You're on mute, Michelle.
Sorry, first time today. I'll come in at the end, Sharon, and just...
Right, that's fine. I didn't know if it was on this point. That's fine. OK, so Mike Cook first, please.
Great report as ever. You've got a grasp and a grip on this, despite the huge surge, particularly around Hull. Well done, Lynn, and all the team. Thank you for responding so proactively and to plan so well that you have. You told us this was going to happen, and it did, and we've responded. Two things then, the sort of game changers around the lateral flow testing. I was just, if you can explain in words of one syllable to me, are we going to measure whether that has a net benefit of staff coming back because they're negative, having self-isolated, or is it going to be a positive effect as well because asymptomatic people are being, suddenly realising actually I'm carrying COVID, I need to isolate. I'm just quite interested to just hear what your early signs and are around that, and whether we're going to measure that impact in some way. And if I can ask John directly, okay, the COVID vaccine, particularly the Oxford AstraZeneca one, is being very much lauded. Can you put your crystal ball on and on the table and begin to think, right, what effect is that likely to have? Awesome. Two easy ones for you.
Yeah, easy questions for you, John.
So just to pick up the lateral flow testing, just to reiterate, it is asymptomatic, Mike. So some of the evidence we've seen from other trusts who've done this using PCR testing over the summer is they have a pickup rate of about 2 to 3%. So we're anticipating, as we've rolled this out, we'll pick up the 2 or 3% of staff who are unwittingly asymptomatic transmission carriers. So so we will know that we're going to sort of have to isolate some staff because of this, but I think it'll be much more difficult to prove the beneficial effect, apart from the fact that we may have less outbreaks as a consequence. So, we know we're in the middle of a surge in Hull. We know there's outbreaks, as been discussed by Lynn and Hilary. So it might be that we will have reduced outbreaks as a consequence of this, but I think being able to prove it will be tricky. Now, I do wonder, you've asked me about my crystal ball, whether the lateral flow testing will also play a potential role going forward with regard to assessing vaccine efficacy. Because if you're constantly testing the people who've had the vaccine, by default, you kind of think you'll build up a database of the people. Now, that hasn't been discussed as part of the lateral flow testing, but that's just me putting on using a little bit of scientific brain of mine to go, actually, that might be a positive outcome of the lateral flow testing, assessing vaccine impact. So, look, just to pick up your question about the vaccine, there's been an awful lot of stuff in the media. I think we've alluded to the fact that we're thinking as a system about how the vaccine is going to be rolled out. And from phase 1 will be healthcare staff and people aged over 80. So it has to be a collaborative effect. The nature of the Pfizer-BioNTech vaccine is around a storage challenge, and we'll be working very closely with Hull Royal, I think, to have a combined effort here to vaccinate staff in the right order based on the risk. So I think there's two parts to the vaccine challenge. One is the logistical challenge of delivering it to all of our staff, and likewise then rolling it out across primary care to GPs. But I think the second challenge is we need to be honest about is the trust challenge, Mike. And I think it's really, really important that we maintain the trust of our colleagues and also the general public with regard to vaccines and their crucial role. And I think part of our communication approach to this will have it fronted basically by senior clinicians, because clinicians talk to clinicians, and it's really important that we maintain that sort of trust, because I think the risk to the vaccine programme for me is if people start to second guess the science and second guess the value of the vaccines, there's a knock-on effect, and then we will lose the positive herd immunity effect which you would get with the 70 to 80% uptake. So I think the trust challenge is a bigger challenge than necessarily the technical challenge associated with a rollout. Those are my views only, Mike.
Thank you. That's very helpful. Thank you.
Thanks, John. That is very helpful. Okay, Francis, next, please.
Thanks, Sharon. Two questions, really. Well, one is probably more of an observation. Yet again, a report, a great report, as Mike says, really detailed, see everybody's on top of it. But yet another report talking about people, stress, strain, etc. So just to flag that when we get to the risk register, we might want to look at the people risk level. That was all. And then within that, I know it says in here we're trying our best to ensure people take holiday, but obviously trying to stay on top of that, and particularly with Christmas coming up, making sure that people within the organisation, including everybody around this table, you know, does get a break over Christmas to recharge the batteries and spend time. And then the second one was more about GP practices. I'm not quite picking up from this where we are with our GP practices and what kind of what's the impact on our GP practices of COVID? How well are they coping? Have any of them had to shut down? Because I know some GP practices have just, because of loss of staff, have had to completely shut down. So I was just wondering where we were with our GP practices, Lynn.
Yeah, thank you, Francis. So obviously, you know, part of our surge plan, obviously, we have the same data in relation to their pressures as we do for the rest of our services. So none of our practices have had to shut due to those types of pressures that we know are out there in, unfortunately, in some of our systems at the moment. So actually, obviously, they have been very busy with the flu campaign. We know that obviously we are preparing them for the COVID vaccine campaign as well. But actually, overall, our GP practices are managing their pressures well.
Thanks.
Thanks, Lynn. Peter Barron.
Oh, thanks, Sharon. Yeah, I mean the graph that you've got there, Lynn, really emphasises the surge that we've had in a very short time, and not included there, but it would be the same shape. Would be Scarborough and probably Rydale as well. The surges that they've had, and I did actually read. I don't know, you don't believe everything you read, but I did read that they had an absolutely massive surge in Whitby. Just in early November, the cases there were like over 800 per 100,000 is what I read, and I just wondered if that particularly big surge had caused any particular problems in that area with regard to the community hospital and also staffing. I know it's, you know, most of the report here is probably a little bit towards Humber and East Riding, but in terms of that slight outlier, if you like, in terms of our geography, did that cause any issues, and if so, we'll perhaps, you know, say how you overcome those.
Thanks, Peter. Yeah, so obviously we are very well connected. I think one of the issues that Michelle would say, we don't sit around the local resilience forum table in quite the same way. So that, and we have raised this consistently because it does mean there's a little bit of an issue with access to the same level of data. However, obviously we are very well aware. It's been really interesting, the pattern of COVID virus in the North Yorkshire and York patch, because it has been very localised, and unfortunately some of those seaside town areas have had some spikes, and Scarborough did as well, and obviously that did impact particularly care homes, where we did see a rise of infection within some of those. So obviously that has meant that our services have had to respond to that, and I'm actually really pleased to say we have been really flexible and agile, and in fact the patch overall complements us on how we've been able to do that. It has been difficult, it has had its challenges, but overall we have managed those pressures well, to a degree that we have really had to sort of mobilise very quickly and support a particular care home in Scarborough a couple of weeks ago that had real issues with its staffing. So again, I think we've managed it, we're keeping a very close eye on it. Internally, I have an OPAL report for every service every day. So they have managed their pressures in sort of a lower level, sort of OPAL 2 overall. And I think, again, that just, you know, describes the sort of flexibility that they've had to manage it. So overall, we've managed it well. Obviously, watching it very closely, we do know that the overall position in North Yorkshire and York in terms of infection has plateaued and slightly going down overall at the moment, but we've just seen how quickly that can change, particularly looking how quickly the situation escalated in Hull.
No, thanks, Lynn. And it may be that, see how it transpires, but maybe in your next report we'll think that it could have changed again in 2 months, couldn't it?
It absolutely could. Yeah.
But if relevant, if you could just maybe pick up some of what you've just articulated, that would be really useful. Thank you very much. Can I just say, I mean, you're right, you've all articulated what a challenging 2 weeks it is. My thanks on behalf of the board and particularly the non-execs to all of you. You've all continued to work in these challenging environments and work extremely hard on top of everything else. So thank you all for that. And you're right, Lynn, to draw the board's attention and for us to articulate the contribution of all of our staff have quite frankly been remarkable. So thank you for that. So Michelle, over to you for the final comments.
Yeah, no, I'll just pick up a couple of bits. On the Whitby Scarborough piece, yes, there are still pockets, and as Lynn said, it's quite isolated. But Scarborough is still a bit of a hotspot at the moment for us in relationship to trend and numbers. The rest is beginning to plateau out in that particular patch, and there is a gold meeting on a Thursday that I attend. So even though we're not quite as involved in the local resilience forum, we do have that. We have stepped up our gold. If you remember, we had gold every day, then we went to twice a week, and then we went to once a week. We've now stepped that back up again, and I think that's been very helpful. We are looking at Christmas holidays. I can assure you I'm looking at it from a director point of view, and also making sure that the directors have a holiday between now and then, because it has been full on over the last few weeks. Hull is still a real issue with rates, and we are in deep conversation at the moment in relationship to what happens next week when the local lockdown, the national lockdown ceases. It's highly likely they'll be in a high tier, so we just need to have a look at that. And there are some guidance in relationship to what that means, because the tier levels have been adjusted and things have been included that previously weren't. I think we have tried to be really ahead of the game in relationship to this, and I think thanks to the team, the structures that we've got, we are staying a bit ahead of the curve. We are continuing to do things like Ask the Exec. We do lots of comms, and I think as we heard from Michelle earlier on, staff are accessing those and finding those very useful. The lateral flow testing has been very positive. It obviously, as John said, it's about 2 to 3% nationally from the testing that's been done in acute trust from a LAMP point of view, which is a different asymptomatic testing, but it does depend on the ground rate. So it's quite difficult to plan, but we are planning on a 3% absence in relationship to that links into our surge plan. In relationship to the staff, one of the things that I have expedited from a system point of view is the resilience hub. Because if you remember, one of the things the system wants to do is to utilise the money that we've got, not just for staff mental health and well-being, but the money we've got from the resilience hub. So we are going to be starting that next week. If you remember, Tuve are our lead provider, but we're working as a system for that. So that should be helpful and supportive. The COVID vaccine planning, as John said, is really intense at the moment, and we will be doing that in partnership with others. There'll be a mixture of larger area for testing, as well as more regional and local. And we are looking with our GPs about how we support them, because obviously the DES has been signed for the GPs, so we need to work with our GPs and how they link into the PCNs. The Nightingale hasn't necessarily been stood up yet, but is still there, and there is still talk about the Nightingale being brought in, but the acute capacity across the patch is good at the moment. So as good as it can be. That there's nothing in the horizon for the Nightingale to be stood up, but that will obviously add to our workforce pressures. So I think for us the next phase is what that Christmas period looks like. There is a non-exec briefing before Christmas. I think you should have that in your diaries now. That'll be a couple of weeks, and obviously we'll do a board pack as we would normally at the end of the month, that will give you a really update in relationship to COVID. But I'll stop there, Chair, unless there's any other questions. But it's a team effort, and I think it's just great how much. But staff are just amazing. They are absolutely fabulous, and we will continue to make sure that they're supported and they are getting breaks.
Thank you, Michelle. Thank you very much for that. Okay, anything else on that? Move on? No, thank you very much for all of that. So if we move on then to the item 18, which is the board assurance framework, and I think this is at page 150 of your packs. Michelle. You're on mute, Michelle.
Second time today. It's once is good, but twice is not good, is it really? So apologies for that. Yes, the board assurance frame, it is here. It is comprehensive. I think I'll just throw it open to questions really. I do think we should have the conversation either at this one, well, maybe at the risk register, about the staff resilience piece and the staff tiredness piece. But it is here, noting the changes, noting the progress that we've made, obviously reflecting on COVID, and it's presented here for just to note and receive. Thank you, Chair.
Thank you, Michelle. And obviously relevant sections have been through the various subcommittees and discussed in detail before it gets here. So I'll start with Peter Barron, please.
Thanks, Sharon, and thanks, Michelle. as part of my audit report, I probably should have mentioned that we had a separate meeting with the internal auditors after the meeting, and one thing they did say was how good our board assurance framework was, and the discussion that we had, how good the discussion was, and the buy-in from everybody. So I thought I'd just mention that now, since I should have probably mentioned it earlier.
Thanks, Peter. That's good to hear. Francis?
Thanks, Sharon. It was just to raise the point I mentioned earlier, which I did raise at Workforce, and I know the exec were going to look at it, but strategic goal for the effective and empowered workforce, that you know, we've been consistently yellow, but we've had lots and lots of discussion around stresses and strains on the workforce at the moment. And if you look at the actual individual risks, there's one yellow, 1, 2, 3, 4, 5 red, and 1 amber. And I know we've got assurance in there about how we're dealing with it, and we've got some good moves on you know, the turnover rates coming down and recruitment improving, but it's just a, you know, to flag, you know, with everything that's going on and the pressure we know the team are under, whether yellow is still absolutely right. That's all.
Yeah, we did pick this up a bit in the Workforce Committee, didn't we, Dean? And Steve, do you want to pick that up?
I think you're probably on mute, so there you go.
Sorry. Yeah, I mean, we said we'd have a look at it. I mean, I think we do need to. It's absolutely that we've picked up some of the pressures that are in there. We've also talked in the Workforce Committee about some of the really good performance things that we've seen as well, though, reducing sickness, reducing turnover, more staff working for us as well. So it's always a balance, isn't it, about how we score it. I think I'm comfortable at the moment at what it is. That's why we put it forward, but I took an action away from that committee to reflect on it and have a look at it, and I will do that and bring it back to the next Workforce Committee.
Thanks, Dave. Anything else on that paper? As I say, I know that the relevant committees have looked at their parts in detail. Thank you very much for that, Michelle. So if we move on to item 19, which is the risk register, Hilary.
Thank you. Yeah, 9 risks on the risk register. We've got that are all graded 15 and above in terms of the where we're looking at the control side of things. 4 are COVID related, and there's our highest risks actually on the risk register. You can see there's still 16 in the current risk score. The remainder are the ones that were on our risk register earlier to a certain extent. So lots of staffing in their workforce, vacancies for nurses, vacancies for medics, being able to retain medics, being able to retain nurses, finance risk in there about having the sufficient money in the tariff to cover what we need to cover, particularly on agenda for change. That's another risk that we've got there. And then the remaining 4, as I said, the COVID ones, sickness absence, the anxiety and fatigue one, which is scoring very high. And as you can see, our current risk, if with all of our current controls, is exactly the same as the risk without the controls. So we do need to do more work around that as well. The reduced bed base as well is another one with all the out of areas that we've got, which are the reasons that Lynn described earlier as well around the out of areas and the surge that we've just had, and the closure of our beds, which obviously impacted on that. So I'd like to think that we'll start to see that coming down as we move forward with not having so many out of areas. So yeah, it's a combination of the COVID gold risk register and the corporate one all brought together to give us the 9 risks that we're dealing with at the moment. So open it up for any discussion, questions. I know we've said we want to discuss around the staffing, anxiety, fatigue element.
We do. So I'll go to Mike Cook first.
I think it was the introduction of the command risk register against our known risk register, if you like, that and if you look at the command risk, and this is why we've got a gold command that stood up twice a week now. All of those risks have a 12-point difference between where it is now and where we want it to be. So they're the risks that they're obviously dynamic ones. At Workforce, we put our finger on this fatigue because it had come up in a presentation, it had come up in the papers, and it had come up in the risk register, and we'd heard you all mention it, including yourselves. So I think that was why we were focused on that. But I think that's the observation I'd make from our current risk register. those command risks, and they are command risks and they're being dealt with through command, there's a bigger gap with the where it needs to be from where it is now. And maybe Michelle just wants to do a brief comment on that, but that's why we have command. I understand, and we're in a crisis. So.
Yeah, no, it's a good point, and certainly one of the things. I mean, we've talked about health and wellbeing of staff, and that's why we constantly talk about it at each meeting in relationship to how we can continue to support staff, show that the value. That's why we stood down a lot of work in July, August, if you remember, to try and preempt the piece, which is why I mentioned in my report about the resilience work and the use of the shiny minds, and that's part of the reason why we link in and we dial into the teams on a very regular basis. And as I said, the morale is high, but there is the fatigue there. But it's just about keeping really close to the staff and really monitoring that they are getting breaks, because the other thing that staff are not wanting to do is take a lot of breaks because they want to wait until COVID's over and they can go on holiday, even though we want them to take that time out. So we have put a lot of steps in. We'll continue to review those steps. I think it'll be one that takes a while to reduce, and then I think we'll see another peak, Mike. So I think it will start to come down. And then I think once we get into either vaccination, the herd immunity, a bit more normality into the spring, I think it'll go down again. I think then it'll hit people in different ways, which is why we need to bring in the resilience hub work, because some of the staff rightly don't want to access our own facilities for whatever reason. So we need to make sure there's other avenues that they can contact. The other thing that we're being really quite fastidious on and looking at it very regularly is risk assessments, not just for our BAME population, but risk assessments in general, that managers are reviewing those, because obviously we've done the first wave of them, but managers are reviewing them as the situation changes. So I think we've got a lot of things, but we do need to constantly review them and say, well, is one working more than the other? And make sure that's reflected in the risk scores. And we do look at the risk register every I think it's every week. But Michelle will tell me otherwise. Michelle Hughes, who is our logist for gold, but we certainly review the risks on a very regular basis. And I don't know if there's anything more that Steve or Lynn want to mention on that point, if there's anything that I've missed.
No. Lynn, you're on mute.
Sorry. What's going on today? I haven't done that at all this week. So I think, you know, it's that constant conversation, and we did touch on this at the workforce NOD committee. I know, and Michelle and I, obviously, we both talk to teams very regularly, constantly asking that question about what more can we do, what in addition can we do. But I think it's all those things together. It's certainly something that I've been raising with my own managers as well. I think it is that constant sort of support and reassurance that is the biggest thing that we can do right now. And although we're all busy and pressured as well, it's taking that time to make sure that those conversations, that people are noticing when, you know, in a team meeting, somebody's a bit quieter than usual, and, you know, really using, you know, all the mechanisms that we've got. I don't think there's anything, you know, more powerful than that we can do. And that is, honestly, it's a daily conversation that we're all having, and to recognise that the middle and the senior managers are very much part of that, you know, and the pressures and impact on them too. So, you know, I know that is happening. People are very attentive to it. But the constant ask is what more as well. I think Michelle says the Resilience Hub will provide another, you know, arm and thread to the support that we've already put in place.
Thank you, Lynn. And I think asking the staff about the health and wellbeing ideas as well will be really helpful.
Yeah, we've funded a couple of those already. We've funded a couple of those already, haven't we, Pete? That have come up, that have been that staff have thought about. You know, if we do this, it will be helpful. And we did. I did have a conversation, as I think I alluded to earlier, about do we do our own, you know, piece of work on resilience that staff can dip in and out of, not necessarily go to a hub and speak to somebody, but you know, tools, because it's about giving staff tools, isn't it? It's about giving staff tools to be able to continue, because it's not just in the professional life or the working life, it's in our private lives as well. and that's compounded by Christmas, etc. But what we've decided is that there's a lot of work already in the Shiny Minds app. So we've done we did a comms, and if you noticed it last week, we did a comms about, you know, do access those programs in Shiny Minds. So we're constantly looking at different things and obviously looking at different areas, but that suffice to say that a lot of areas are looking at what we're doing and using what we're doing to roll it out. I mean, Claire mentioned it a couple of days ago, Claire Murdoch, about some of the stuff that we've done, but we will constantly keep looking and asking staff what they need and what we can do for them.
Yeah, that's good, thank you. John, I'll come to you. And just one thing, John, as well, might the new recovery college forum help some people as well, because there's a range of things on there as well, isn't there, that might help some people. Anyway, over to you, John.
So just a quick observation, bearing in mind my military background, where you tend to do an operational tour, which lasts 6 months, and you have a month build up and then a month when you come back. And already in the NHS, we're already into 8 months of a tour. But the one thing that I'm reminded of when I did my military tours is that when you come back, there's a huge appetite for change for people. Now, it's not about the grass being greener in other places, but people just need to feel the need to move, whether that's from a personal perspective or a professional perspective. So getting all of our resilience offers right is really important, and I know we're investing in that. But I do wonder across the broader NHS whether or not come March and April, people will just start looking around because of the effect of COVID on them and the sort of the length of this particular, dare I say it, operational tour. So I don't know, there are other HR experts who might have a view on that, but based on my military experience, it's something I think I'm cognizant of, that people just might have an appetite for change, whether or not it's that, you know, you're jumping from the pan into the fire or not.
No, thanks for that. I'll come to Steve and then to Lynn, please. So Steve, you first, please.
So I suppose, Sharon, just the reflection would be, and I think we've put loads of support in for staff as has already been described. I think a lot of that is kind of at the dealing with this because it's in it, rather than trying to take some of it away. And I'm not saying I'm sitting here with any answers that we have thought about this as EMT. So, you know, this isn't a statement or a criticism, and I know we keep reflecting on this all the time, but you know, the ask from the ICS, for example, and the ask internally of what we're putting onto staff. So I do wonder whether there's still some scope, maybe something we touch on in board timeout, about what can we temporarily stop doing or supporting, not necessarily in a service delivery, but that kind of infrastructure level that impacts on particularly our middle managers, to stop the work, as opposed to providing support in for people when they are overloaded and how they deal with it. And I guess that's just something that we do wrestle with at EMT. I think it's something that we should always keep checking back in at and seeing what we can do, even if it's just for a period of time, to get that kind of breathing space. Otherwise, picking up on John's point, I do think there's a real danger that across the NHS we may see people saying, that's me done. I've got through this. I'm now going to walk and do something different. And I think that could cause us an issue across the whole bigger system if we're not careful in how we try and manage this.
Thanks, Dave. Lynn.
Thank you, Sharon. I think it's an important point that Steve makes there, but just I think you were making a point specifically about the Recovery College, and you were at the launch of the online platform. So just to reassure you, obviously we've already connected our Recovery College offer to our service users with our staff offer, but that development of the online platform obviously gives us even further opportunity. So that is on the agenda for our next staff health, wellbeing and engagement group, to connect that in and make sure that that offer is published to our staff as well.
No, that's fantastic. I was very impressed, Lynn, and it just seemed to me that now most of it, that part of it is virtual, that our staff could be able to access it as well. And it looked as if it was very much geared, as you would expect, to a lot of the things that we've just been talking about. So as we're doing it for, you know, and providing it for our patients, it just struck me that it would be really helpful for those who wanted to access it for our staff as well. So thank you all for that. So are we resolved to leave the risk register ratings as they are then, having had this discussion for now, and then review through all of the various governance routes that it does take through silver, gold, all the committees on a regular basis? Are we saying that, or are we saying change it? Are we saying leave it? Yeah. Any advocates for changing the rating? No, okay, well, it's been a good discussion, but we will leave it as it is. So if we can move on to item 20, which is the charitable funds annual accounts. Pete.
Thank you, Sharon. So accounts are attached. They have been through the Charitable Funds Committee. I think it's important to note that they are unaudited accounts, but they have had an independent examination. We did amend them slightly at the Charitable Funds Committee, so we asked for additional text to be included in relation primarily to future plans, and that probably covered, work with BAME and utilising the NHS charities money, work on the Whitby appeal, and probably work to maximise the utilisation of funds for the Brudens community, which we talked about earlier on the CFC assurance report. So I'm happy to take it as read and go to any questions if anybody's got anybody.
Mike Smith.
Yeah, thanks, Pete. There's a little bit of a fundamental issue within this, and I did raise it in a meeting where Michelle Hughes wasn't present, and that's whether the board is approving these things or whether the corporate trustee is. Now, the charity is a separate legal entity. It's not the board. The powers to approve the accounts are for the corporate trustee, and they don't come through our scheme of authority. Despite what it says in paper 22 that's coming up, those powers come from the establishment of the trust deed. So the trust isn't the charity is the charity. So when we approve these accounts today, if we do approve them, we don't approve them as a board, we approve them as a board acting as the corporate trustee. And when you come to page 5, the Humber NHS Foundation Trust Board devolved responsibility for ongoing management of funds to the Charitable Funds Committee. No, it didn't. The corporate trustee delegated them. The fact that the two things are the same in membership terms is irrelevant to the charity being a separate legal entity. Do I make sense?
You do, Mike. Michelle Hughes.
Oh, sorry, on mute. Yes, Chair. So whilst Mike was speaking, I was just pulling up the relevant section in the standing orders, and it actually says directors acting on behalf of the trust as corporate trustees of the NHS FT charitable funds are accountable for charitable funds held on trust to the Charity Commission.
Yeah, okay, that's fine. But we are acting as corporate. Just to be clear, just on this item, we're acting as corporate trustee, aren't we, Michelle?
Yes, we are. Let me just read that.
I'll drop you a note offline about some of the wording, if that's all right.
I will. Section 4 of the standing orders covers it, but I'll pull out the extract and share it with you, Mike, just to provide assurance.
That's brilliant. Thanks ever so much.
Okay.
No, it's a good point, Mike, and it may be, Pete, that we just need to make clear in some of the wording that that's the case. But it's what we're doing, so that's fine if we do that. Thanks, Mike. Mike Cook.
Thank you. Just technically, we took the item at the 3rd of November, Charitable Funds Committee. It says the 12th in the report, but it was the 3rd, and we recommended and endorsed them subject to some technical work that Peter and Pete then did, and we had them presented by the people who do the accounts for us. So it was a good process.
Thank you, Mike. Anything else? I've just got a couple. Can I just ask about the level of debtors? I can find it on page 182. It seems quite high. What's that relating to? If I've read, it just says debtors unrestricted fund 132,000. Have I read that right?
You have read it right. I'd have to take that as an action, Sharon, and come back to you as a post-meeting no.
Just seems a bit high, that's all, for debtors.
Sharon, I suspect that's probably prepayments in relation to the CAMS charitable fund, the Inspire units.
Okay, well, if you could just circulate a note round afterwards, Pete, because as I say, for a level of, given the level of some funds that we're talking about, that's quite high level of debtors. And my only other one, I think, was I make it each year, I think, we refer to employing 3 staff, but we don't employ them, do we? Aren't they doing through Smile?
Smile employ them directly, yes.
Okay, well, if we could perhaps just make that clear, because it implies that we employ them. And the other thing is just if we could just insert that Paula B was a non-executive director, because with hers it's just blank in her capacity, whereas everybody else has got their role. That would be just complete that, please.
Yeah, no problem.
That's great. Well, so subject to those changes and subject to Michelle and Pete just looking at the wording about acting as corporate trustee, are we happy to, I think we're asked to approve them. I'm just getting to the recommendation. We're asked to approve them. Acting as corporate trustee, are we happy to approve them? Yes. Any dissensions? No. Fantastic. Thank you very much. If we could then move on to item 21, which is the Ethics Advisory Group Action Log. John?
Thank you, Chair. So the Ethics Advisory Group is a group which sits at the request of Gold, and Gold asked us to sit to consider challenges with regard to visiting, and particularly at that stage we were starting to see the first stages of Hull becoming the epicentre with regard to the pandemic. So these are the notes of the meeting, and we've attached some of the documentation as well. And I think, Peter, it links back to a question you might have asked at the last board meeting from memory about how we were approaching visiting in our services. So I hope this provides you with some assurance as to the nature of the conversations that have taken place and the communications that we've put in place. I have to say this is a dynamic situation, bearing in mind we've just talked about lateral flow testing, and we've also talked about the rollout of vaccine. I wonder if in 6 to 8 weeks time we'll be going around the buoy again in terms of visiting and putting in place perhaps lateral flow testing. And you know, I'm just thinking aloud here. I'm wondering, you know, will we be thinking about the challenges of visitors towards who haven't had their vaccine compared to the people who have? So just some of those things to think about in the future. But I think we've had collective engagement from all of our colleagues on this. And I'm particularly grateful to our infection control colleagues who've done some sterling work and sort of in terms of trying to make sure that we can keep the wards safe. But if we go back to Joan's board story this morning, it's heartbreaking. It's really, really difficult for carers and family members. As you can also hear, it's really difficult for our staff who are used to having family members come and support their work. But I think Hilary and I would reflect back that we had this innate fear back in March and April that our most vulnerable patients, particularly our elderly ones, were going to succumb to COVID, because if it gets into one of our wards, it'll go around like wildfire, even with the best efforts with regard to PPE. So there is a balance here, and I think that we've tried to capture that balance through the Ethics Advisory Group conversations we've had so far.
Thanks, John. Really helpful. Any comments or questions on those notes? No, thank you very much for that, John. If we can move on to item 22, the review of standing order, scheme of delegation and standing financial instructions. Michelle Hughes.
Thank you, Chair. So an annual review has been undertaken on this key governance document and 3 amendments are proposed. They relate to the authorisation limits for charitable funds, so that any expenditure above 25,000 is reported to board. For any charitable fund schemes over 100,000 to be approved by board. And finally, a new category to be added to single tender waivers to reflect the emergence of the lead provider and strategic commissioning arrangements. The changes have been discussed and supported in audit and charitable fund committees. Further in the report, it details how they'll be reflected in the actual document, and subject to approval will become effective immediately.
Thanks, Michelle. Any questions or comments from Michelle? Mike Smith?
Yeah, it's just the same one. If it's necessary, Michelle, it's again the board to take to the trust board as corporate trustee for approval.
Thank you. I will do.
Well, against that backdrop, which Michelle will check, are we happy to approve the changes? And if once Michelle reviews it, also give her, and she thinks that that wording needs to be changed slightly to reflect the corporate trustee point, then Michelle will just send an email around recording that's what's happened. Is everybody happy with that approach?
Yes.
Yes. Yeah. Thank you, Michelle, for that. So on to item 23, which is items for escalation. I don't think there have been any. Has anybody got any? No? Any other business? Not aware of any? No, well, in that case, we will bring our part one, a meeting in public, to the end. I'd like to thank anybody who has joined us virtually for joining us, and to wish you all a happy Christmas. Christmas is a month today, and our next board meeting in public will be at the end of January, so please do join us then. But in the meantime, have a happy Christmas and a good new year, and stay safe. And thank you very much for joining us. And I'd just like to reiterate my thanks on behalf of the non-exec team to the exec team, as well as all of the staff, for everything that you've been doing, because it is an exceptional time and it's been an exceptional few weeks, and I'm sure it's going to continue to be an exceptional time going forward. So thank you to you all. So board members, we will close, as I say, part one meeting. We can stop live streaming, please, Adam, and then we'll just stay on the line.